Sure, sir.
Yeah. So can we start now?
Yes, sir, we are live.
Yeah. So good evening, everyone, and welcome to Pan Ophthalmologica 2025. And today is the World Sight Day, 9th of October, and we have an array of talks which are here. And for the uveitis scenarios, we have a little change of schedule. Dr. Mudit will be presenting first. So I would request Dr. Mudit to start his presentation on identifying retinal infections. Dr. Mudit, please.
Thank you
He
so much.
is at
Yeah.
the L.V. Prasad Eye Institute and we all know him. Mudit, you can please start.
Yeah. Thank you so much, Dr. Mayur. Thank you for the uh, kind introduction. Just give me 1 second. I'll just share my slides. Okay. So are my slides visible?
Yeah.
All right. Thank you so much. And first of all, thanks to all the moderators of this session, Dr. Mayur, Dr. Prabjot, Dr. Neha Mohan, and to Vaibhav and the team at Pen Ophthalmologica for another year of great cases and very interesting program. So I will be talking about pattern recognition in retinal infections. Now, the good part about retinal infections, as far as clinical skills are concerned, is that a lot of these diseases can be identified based on how they appear. And based on the clinical features, a lot of times you may not need to resort to too many. A lot of times, most of these are clinical diagnosis. So all you need is to identify the pattern or get into the habit of recognizing these patterns and look at your patient more clinically and with slight more details to be appreciated. So like I said, why does pattern recognition become important? Because most of these infections follow a pattern. They adhere to certain specific patterns in terms of their morphology, in terms of their appearance. And if you start identifying them, you will be able to identify them earlier. You will be able to treat them quicker, and you may not need to resort to multiple investigations as such. So before we move on to what different infections can look like, it becomes important for us to first of all understand the plane of the infection. Is it infecting predominantly the choroid or is it a retinal infection? Remember, there will be a lot of times an overlap. What starts in choroid may move into retina and vice versa. But looking into the appearance of the lesion, a lot of times you can determine whether you are dealing with a choroidal lesion predominantly or a retinitis lesion. And the clue lies in looking at the blood vessels and the appearance of the lesion. So retinitis lesions, because they are in the retina, will be slightly more superficial and they will obscure an underlying blood vessel. Choroidal lesions, on the other hand, appear deeper, number one. Number two, you will be able to, in most cases, appreciate blood vessels coursing over the lesion. So you see a deeper elevated lesion with a blood vessel coursing over it. It means that there is a choroidal involvement in that lesion which you are seeing. So like if let me show you just one more example. So you see this lesion over here, which my pointer is working upon right now. So you can see it's a slightly deeper lesion and you can see blood vessels coursing over it. So that's a choroidal lesion as compared to the one on the left hand side over here. Now, if you see this lesion over here, what you predominantly see is a superficial lesion which is obscuring the underlying blood vessels. So this is a retinitis lesion, and we'll come to why and what this disease is. Though it's actually a toxoplasma retinochoroiditis, but we'll come to identifying it later in the subsequent slides. What I want you to listen and appreciate at this point of time is the fact that this lesion over here is superficial, obscures the underlying blood vessels. The one on the other hand over here is deeper, and you can see blood vessels coursing over it, meaning thereby it predominantly is originating from the choroid. Now, there are certain specific signs which are very characteristic. They may not be absolutely 100% absolute, but they will help you in pinpointing and making you focus in a more channeled way. So, ocular tuberculosis also has got its signs over here. If you look at this lesion, an occlusive vasculitis, number one, broad-based synechiae. If you see this subvascular pigmentation, that is actually very characteristic of ocular tuberculosis. So subvascular pigmentation, broad-based synechiae, occlusive retinal vasculitis, and disc edema usually can be a manifestation in a lot of diseases, including sarcoidosis. But the ones which I want you to remember more clearly are an occlusive vasculitis, number one, and lesions with subvascular scarring, number two. So these are very characteristic of ocular tuberculosis. One more very interesting point, and this is courtesy my friend Anamika Patel, who got this investigation done when she was in Vizag in our GMRV campus, is a retinitis overlying a blood vessel. So you see this retinitis and you see an underlying blood vessel which is slightly tortuous. So this focal vascular tortuosity and a retinitis and overlying a blood vessel again is a clue to the fact that you are dealing with ocular tuberculosis. Serpiginous-like choroiditis is another very characteristic pattern. Usually, you will see these lesions which will be sparing the peripapillary area initially, though later on they may progress. So, multiple lesions appearing in a serpiginous pattern, sparing or juxtapapillary are again a clue to a serpiginous-like choroiditis. So, these are patterns which are pretty characteristic of ocular tuberculosis. So, these are the ones which you need to keep in mind. Number one, an occlusive vasculitis. Number two, subvascular scarring. Number three, a serpiginous-like choroiditis. Moving on to one more very common retinal infection, which is toxoplasmosis. So unifocal retinitis or a unifocal retinochoroiditis usually in most cases clinically heralds an underlying toxoplasma infection. This can happen in immunocompetent as well as immunocompromised host. There is a frequent involvement of macula. There is no consistent direction of spread, and you may occasionally have an associated intense inflammatory reaction. In fact, if you see a very intense reaction and you see an underlying solitary retinitis lesion through that obscuring retinite vitritis, usually it is toxoplasma. If through that intense vitritis you see lesions in the periphery, confluent in the periphery, usually ARN. So two diseases which are very significantly associated with dense vitritis are toxoplasma and acute retinal necrosis. Difference being usually toxoplasma will be at the posterior pole predominantly. ARN usually predominantly happens in the periphery. So multiple confluent lesions in periphery, and I'll show you some of them later. The other point to remember is usually toxoplasma lesions recur adjacent to a scar. So if you see a scar and you see a retinitis lesion adjacent to it, your diagnosis is nearly always confirmed. You are dealing with a toxoplasma retinochoroiditis. So this is another patient. And now this is one patient who was initially thought of as a CMV retinitis by somebody else. But if you look at it carefully, you see a large scar and you see a lesion adjacent to it. And that in itself is a telltale clincher. You are dealing with a toxoplasma retinochoroiditis. Now, the other point which you need to remember, one more other characteristic clinical clue is looking at the pattern of reactivation. So reactivation at the edge of a scar, toxoplasma. Reactivation from the center of a scar is sometimes seen in tuberculosis. So reactivation from center, think TB. Reactivation from edge of the scar, think toxoplasma. Moving on to one more classical disease, CMV retinitis, and how does it come to you in a pattern? Multiple areas of retinitis, arterial sheathing, some areas of hemorrhages over here, and a central clearing. This appearance is usually very characteristic of a CMV retinitis. Now remember, CMV retinitis is predominantly seen in patients who are seropositive and whose CD4 counts are low. But you also need to keep in mind the fact that if other patient is otherwise immunosuppressed, meaning thereby post-transplant patients, patients with underlying blood dyscrasias like non-Hodgkin's lymphomas, and patients who are on long-term immunosuppression, or somebody who has been given depot steroid. All of them can also present with CMV retinitis, so you need to keep that in mind. Now, the other point is that CMV retinitis usually has got a very minimal AC and vitreous reaction. And the reason for that is that your patient is so immunosuppressed that they do not have a capacity to mount an immune response leading to vitritis. So if you see a patient with retinitis, with vitritis, which is out of proportion or much less in comparison to the retinitis that you are seeing, that is a clue to the fact that you have got a patient who is immunosuppressed, and therefore you need to investigate in those lines. CMV retinitis also comes with its own characteristic patterns of this intense retinitis with hemorrhages. Apart from that, you can also see this appearance, which is called a characteristic frosted branch angiitis. So like I said, remember absent or minimal vitritis, extensive hemorrhages and retinitis. You can also have this, which is called a fulminant form. Apart from that, sometimes you can have a granular form, and both of them have got different reasons for a decrease in vision. So loss of vision in a fulminant form is predominantly because of a macular involvement, whereas the granular variants are the ones which you need to keep on following, because usually sometimes they may present with an area of necrosis, which leads to a subsequent rhegmatogenous RD, which can happen in the area which becomes necrotic and creates breaks. So in these eyes, you may have a RD because of the multiple breaks, and so you need to carefully follow them up. Like I said, you can have a perivascular form, which is also called the frosted branch angiitis. What we do also need to remember when you see this frosted branch angiitis is the other causes of frosted branch angiitis. So this was one more patient of SLE who presented with this intense vasculitis and frosted branch angiitis. So remember, it happens in idiopathic, Behçet sarcoidosis, You need to get a complete blood picture and a peripheral smear done for all your patients of frosted meningitis, because occasionally it can be a manifestation of an underlying leukemia or even a lymphoma and SLE. So whenever you see that frosted meningitis, check for HIV, check for Behçet's, lymphoma, leukemias, SLE. Remember, complete blood picture and peripheral smear are very easily doable tests which can shed a lot of light on these diseases. Moving on to one more disease, which is something which we are seeing again and again in our clinics, and one more disease which follows a very characteristic pattern which we should be able to identify just based on its appearance, ocular syphilis. Syphilis can present with multiple forms, one of them being a ground glass retinitis, like what you see with a peripheral transparently opaque ground glass retinitis with a central clearing, or with these multiple yellow mealy lesions. Can happen in immunocompromised as well as immunosuppressed hosts. You can have this placoid retinitis, and I'll show you subsequently. You can have these multiple Merelli lesions. And remember, syphilis is a great masquerade. So ideally, all cases of uveitis should be investigated for syphilis at the time of their initial presentation. So this is what I was talking about, a placoid chororetinitis, so a placoid lesion with more intense infiltration at the edges. You see that is very characteristic of syphilis. And when you get an OCT done, you see this multiple RP nodularity and photoreceptor damage. So whenever you see this RP nodularity and photoreceptor damage with a placoid chororetinitis, think of syphilis. Multiple small yellowish mealy lesions, and if you do an OCT, you see this full thickness retinitis, again a very characteristic clue to syphilis. And this ground glass sort of a retinitis with a central clearing. So these are appearances which are very characteristic of ocular syphilis. And whenever you see such an appearance, keep in mind the fact that you probably may be dealing with it, and this can be identified clinically. So this is what we were talking about, multiple mealy lesions and a full thickness retinitis on OCT. So this is the pattern recognition which I want all of you to take back. A placoid region with intense infiltration at the margins, syphilis, ground glass retinitis with central clearing, think of syphilis, multiple mealy lesions, again, think of syphilis. So this was how pattern recognition helps. So this was a patient who had presented to our clinic, was being treated elsewhere, initially diagnosed as intermediate uveitis, was started on IV methylprednisolone. The patient did not respond, then was started on steroids, did not respond, received systemic immunosuppression in the form of azathioprine, and also got an Ozurdex, an implant which you can see in this fundus photograph. But when we saw the patient for the first time, what we saw were these multiple small mealy lesions. And that set the bell ringing. We got the patient investigated. He came positive for TPHA as well as HIV. This was a recreational drug abuser. He was started on penicillin, which is the treatment of choice for ocular syphilis. And within 14 days, his vision improved from counting fingers close to face to 20/40, 20/50, which is how miraculously syphilis responds to treatment. The only trick lies in identifying it. So like I said, if you remember, we had discussed about peripheral retinitis with vitritis and think of ARN. So this is one patient with acute retinal necrosis. And these again can happen in immunocompetent as well as immunocompromised hosts. Usually, unlike toxoplasma, these are located in the peripheral retina. They have a circumferential spread and may be associated also with occlusive arthritis. So this was another patient of acute retinal necrosis with this intense peripheral arthritis and vasculitis. But what I want you to remember is this confluent peripheral wedge-shaped retinitis lesions start in the periphery, move centrifugally. One more disease which happens exclusively, predominantly in systemically immunosuppressed patients is progressive outer retinal necrosis, where you can see this retinitis at the posterior pole with some amount of perivascular sparing, what we call the mud-cracked appearance. Again, minimal AC or vitreous inflammation because these patients are significantly immunosuppressed, has a rapid progression, so needs to be treated aggressively with intravitreal ganciclovir and systemic antiviral treatment, along with possible systemic treatment. If your patient is HIV positive, you may need to start them on antiretroviral therapy. One more pattern is Candida endophthalmitis, and Candida usually will have this appearance of a single solitary lesion occasionally. Aspergillosis, on the other hand, is more widespread. And this is a very nice paper by Dr. Invernizzi and his group where they have described this appearance called a rain cloud sign, which is seen on OCT, again, which is pretty characteristic of a Candida endogenous endophthalmitis. So in the interest of the time, I think I'm already on 30 minutes. I'll just show you one or two cases which show how pattern recognition becomes important. So this was a patient who presented to our clinics with this decreased vision and these lesions in both the eyes. When we did an OCT, you can see this subretinal exudation over here, and subsequently one of the OCTs also showed this rain cloud sign where the lesions have burst through the retina and are now progressing into the vitreous. While the initial microbiology came negative when we took a sample because of the appearance, we treated this patient on lines of candida and ophthalmitis. This patient got amphotericin B. The next biopsy, which was repeated, actually came positive for candida, and this OCT appearance and clinical appearance actually helped us in deciding our treatment even before we got an access to our microbiology reports. This is a patient of aspergillus, which has got a much more extensive subretinal spread as compared to a candida. Deep retinal with horizontal enlargement can also have an associated hemorrhagic vasculitis.
Dr. Mudit, please wind
Yeah.
up.
Yeah, so I'll just wind up. So this is my last slide, which basically just shows how important pattern recognition is. So this was a patient who presented to us with this retinitis lesion, had received Velacivir and Ganciclovir for ARN. But if you look carefully, you see there's an adjacent scar. So this was a scar and a lesion adjacent to it, which, like I said, basically points to a toxoplasma. So we stopped intraviral treatment, started this patient on Bactrim and Clinda, and look at how the lesion responded. So in a nutshell, I believe that pattern recognition is a very important thing. Most of the retinal infections follow a classic pattern, and we need to just keep on training ourselves in identifying them. Thank you so much. I'll stop
Thank you,
my.
Dr. Mudit. And that was an excellent presentation, lot of cases. And in the interest of time, I would like to now call upon Dr. Prabjot to continue the session with the next speaker.
Thank you, Dr. Mayur. So I think we'll move on to our next speaker, Dr. Salam. He is an associate professor of ophthalmology at the Harvey and Bernice Jones Eye Institute at UMS, and he also is the director of uveitis services and residency program director in the UMS ophthalmology department. He has authored many peer reviewed articles and book chapters, well over 70 plus, and has 100 to 150 plus publications, and is very active in clinical trials related to uveitis and retinal diseases. So we're very honored to have you with us, Dr. Salam. Please, he'll be talking to us on management tips and tricks or pearls in managing retinal detachment in uveitis patient. Over to you, Dr. Salam.
Yeah, thank you so much. Very kind of you. Thanks for the introduction. I've been a professor for nearly like 8 years now. So, but you made me feel younger, which I'm happy to.
My apologies.
Yeah, no, not at all. I thought for the interest of time, I just share with you a case, and then we can embark more on the discussion of retinal detachment. So let me share with you a case. And actually, I have more questions to you guys and to the floor more than what I'm going to present. So let me just share it with you. Yeah, this is a case read that intrigued me for a good time, and I'll show you here. This is can you see my presentation? Yes.
Yes.
Okay, thank you. So this is a patient who came with a 70-year-old female with history of acute myeloid leukemia and bone marrow transplant, and she's on immunosuppressive medicines, including chemotherapy. 2 weeks, decreased vision in the left eye with some pain, not too much. And the other eye is completely fine. She's pseudophakic, 6/6, 20/20 vision. And this eye, she's hand motion, pressure is low. She has anterior uveitis with KPs, some of the mainly pigmented, and she has cells in the antechamber. She has 1+ vitreous haze, and she has this appearance. So she has you can see the KPs like on the optus there. So that's the KPs on the optus. She has a bit of a vitreous haze. She got this whitish lesion there, but also she got a bit of subretinal fluid here, as you can see here. And that's and that's and in the periphery, which is not shown in this picture. She had a very shallow, like more obvious retinal detachment rather than more than what I'm showing in the OCT here. And she has a choroidal detachment. And I was trying to interpret the findings together. Is this really like a retinitis lesion, or and in the context that this patient is immunosuppressed, I should be dealing with infection? And Dr. Moody, the previous presentation, gave a real lovely one, which is pattern recognition. I think one of the important things to ask yourself when you're dealing with any case of uveitis, number one, does this patient have infection? That's number one. And number two, does this patient have a masquerade, very important, neoplastic and not, or non-neoplastic? And number three, okay, if I'm sure that this is not, or like it's hard to be sure, 99% sure, okay, we're dealing with a non-infectious etiology now, and let's just try things and see where we go from here, especially with new cases. So I was asking myself, is this uveitis related to this whitish lesion, or this whitish lesion something she had? Because really, I couldn't tell much, and the view was not very good. Anyway, so I thought I'd just give myself a day here or two. So I gave her on steroid treatment. I gave her prednisone steroids. I thought, what's happening? And that's 2 days after her prednisone drops. Her anterior uveitis got really better, and the view got better, but I can no longer see the whitish area, and she has more retinal and choroidal detachment. So I think the important point here, okay, well, we have more detachment going on here. Is this an exudative detachment, or that's a rhegmatogenous detachment? How does link to the whitish lesion I saw? And what shall I do really now? And that's my point here. I wonder if my presentation is very short. I wonder if I can stop for a minute, and maybe if someone can give direction, just what do you think here, and then we can move on here. I mean, up to you. You tell me how you want to do it.
Usually when, okay, Dr. Neha, you want to go first?
Yeah, okay. So we see that peripheral white lesion, which to me looks like a retinitis.
Yeah.
Moreover, I think the pressures were very low. Yeah, I think it was 6, right?
Yes, yes, yes.
So the hypotony probably is leading to the choroidals.
Yeah.
It's a cyclical process. And then the choroidals are the further converting into probably exudative detachment. And yeah, but because you have retinitis, so you can't rule out the possibility of rhegmatogenous too.
Yeah, I think that's exactly, you summarized really beautifully, honestly. And I think, again, I put things together. I think there's this area, at least I would consider as a retinitis. It doesn't look like a very active lesion, but I mean, there's probably a retinitis there, or at least we have to presume it's retinitis and it's exudative rhegmatogenous. I thought because it got a bit better with the steroids, but the detachment is worse, it's most likely a rhegmatogenous, but I wasn't sure. So then I decided to go in the eye, and that's, I think, a problem as well, because you may convert exudative detachment to a very difficult to deal with rhegmatogenous detachment. So I think few things were going into my mind. First, is it this exudative versus rhegmatogenous? But then I decided to go for surgery because the detachment was going worse. And I think here, and I think this is the challenge of uveitis 3. You link lots of things together. You link the uveitis diagnosed, infectious versus masquerade versus inflammation. And that actually has implications not only on this eye you're dealing with, but also on what happens with the other eye. If it's an infectious process, you're not recognizing it. And the second thing, patients sometimes have anti-segment problems if you're going to go for surgery, and you have to know how to deal with these problems. And the third, if you're going to do retinal surgery yourself or communicate to a colleague, you need to communicate a clear picture of the problem. Because one of the issues here is how to place the trocars with that raised detachment and the choroidal detachment. I think the message really when you're placing the stroker, the first stroker is the most difficult in the context of hypotony. And I would put it very anterior. If you're going to go into the lens, you go like this. What you saw me happening here, usually we do a vitreous biopsy under air, but the situation was too complicated to do anything with the vitreous. So this is what I did here. I just put one trocar and I took an AC tap for aqueous to send it for viral and toxo PCR, because I knew it would be difficult to get a vitreous sample. So that's the second step here. Then the third step, which is very, very important, you don't open any infusion before you check it's 100% in the eye. And that's here, the infusion in the eye. This one is a bit easy because the patient is pseudophakic. Difficult if the patient is phakic. but that's number 3 here. And then the other trocars, and you go anteriorly as if you're going into a crystalline lens. You go like this and anterior. Then the question is we look to, is this exudative or rhegmatogenous? So you remove the vitreous carefully and try to look what's happening and get more understanding. And that's really would be nice to be on shave mode. And I'll show you here. And then we're going, looking for the retina and see what's happening. And all I can see. And this is the money shot here. You can see here 3 things. One, there's a bit of pigmentation there. So there's a process which is healing. And the second, you can see the whitish area here, but the money shot is here. You'll see it here. The money shot is here. There's a schleren coming. So there's a fluid coming from next to this whitish area. So I think to put it together, it's a retinitis, which is not very active. So an organism that is not so active, like not a very aggressive organism. That's again my interpretation. Next to a healing area, retinal detachment, and inflammation and hypotony and choroidal detachment. So that's how I deal with it. I did a drainage retinotomy superiorly to drain the fluid, just to be able to get control on the eye. You can see the choroidal detachment getting worse with drainage. But in my mind, this is a superior detachment. I just need some gas fill, and that should be enough.
I'm sorry to
And then,
disturb you, Salam. Yeah, so do you think this could be CMV, like Dr. Mudit was talking, the granular variety of CMV, which can be
yeah,
associated with the retinal detachment?
yeah, absolutely. I think you're right. Absolutely. I was thinking actually 2 organisms, and I think that's the beauty of this paper as well, the beauty of this case as well. Is organism here you're dealing immunosuppression. So it could be, if you look at all the organisms, what I was thinking of is either viral, and most likely would be a CMV, not like a herpes simplex or zoster, because they are more aggressive, or toxo. And toxo in immunosuppressive patient just can present as an immunosuppressed patient can present anything. That's what I was rethinking of. And
how
then I
long?
later,
Yeah, I
sorry,
was saying, how long did you wait to decide to go in for a VR intervention when the patient
2 days,
presented? 2
2
days.
days. Yeah. And then what actually happened and this is here, and this is one day after the surgery, we have like a 80% gas fill, although I did not drain the choroid. And again, the reason I did not drain the choroid, there was superior detachment. I just needed some gas to support there. And then 1 week after, you have about 40% fill. And what happened is this patient, I think these are the take-home point, but the aqueous came back actually positive for CMV, so retinitis. So that's the aqueous sample. But in my mind, it's either a CMV or toxo. It's like it's a non-aggressive organism. That patient actually, there's a bit of healing happening, but it's just the patient is immunosuppressed. And I think these are my take-home point really when you're dealing with uveitis in the context of retinal detachment in context of uveitis. Traction is easy to know. The question is always exudative versus rhegmatogenous, and you have to put things together. Also, a nice trick is really the OCT of the retina, especially when it's getting worse. If you see more folds with the OCT, that's more likely a rhegmatogenous process than exudative. And sometimes you really need to try medicine or get in the eye. Trocar placement. I think superior choroid detachment, you don't need to drain them. Retinitis differential diagnosis, and more important is the retinitis differential diagnosis in immunosuppressed host. And I think the order infection, masquerade, then we're dealing with inflammation. Thank you.
Yeah.
Thank
Thank
you.
you. Just a question. What if, after going inside, we would have realized that this looks more of exudative and we find a retinal break? Would it be criminal, or would it be still better? We would have drained it anyways and probably filled it with oil.
Yeah, it's a difficult one, really. I know I had this situation several times. Sometimes I'm bold enough to say, actually, that looks exudative, and I just come out. And sometimes I'm not sure, and I would do. So I have a protocol to look for eyes where I think this is a rhegmatogenous, but I cannot find a break. And that protocol ranges from surge, injection of subretinal blue dye, or a drainage retinotomy and laser dry to dry. So I would may just say, okay, actually this is exudative. Let's stop here, be confident and see what happens. or I may look for a break doing all these things, ending up with peripheral laser dry to dry. It depends how confident I am and how things are looking to me.
But how bad can it go if we are actually operating an exudative retinal detachment? We just decide to make retinotomy, drain it well, and just decide to put an oil. So would it be like a bad choice once we have entered and now we
I
are
think,
not?
to be honest, less is more. I hate, I mean, literally, I hate silicone oil in non-indicated cases. So I would not really use oil except in cases that are not seeing well or have like significant retinal traction on breaks. Otherwise, I would not use oil. So I would not use oil in this situation. I would use always gas. But I mean, I mean, less is more. I don't want to create to convert to exudative rheumatologinist unless you're not sure. So that's my take on things.
Thank you, Dr. Salem.
Yeah, thank you.
I would like to invite Dr. Nicola. And Dr. Nicola is there?
Hi, good morning, everyone.
Yeah,
Or
it's evening.
good evening for you. Sorry.
Yeah, so Dr. Nicola is an assistant professor at Baskin Palmer Eye Institute, Miami, and she specializes in ocular oncology, uveitis, and medical retina. She spent 2 years as a research associate on ocular oncology service at University of Cincinnati and completed her fellowship at Wills Eye Hospital. She grew up in Italy, and we believe that she can speak 3 languages, which is English, French, and Italian. So we are very happy and honored to have you with us today. And she'll be talking about inflammatory clinical manifestations of intraocular tumors. To you, ma'am.
Wonderful. Thank you so much for having me. Can you see my slides okay?
Yeah, we can see them.
All right, wonderful. So I'm going to switch gears here a little bit. Thank you so much for the kind invitation and for the kind introduction. It's a pleasure to be in part of this amazing group. So these are my disclosures, which are not relevant to this topic. So I'm going to start with a case. This is a pretty typical case of a 54-year-old man that came with an inferior visual defect that was progressively expanding in the past couple of months. His past medical history was otherwise unremarkable, and you can see that the vision is decreased in the right eye. And as you look in the back of the eye, you see that there's a pigmented lesion superior to the optic nerve with a localized Brooks membrane, and that's where you can see some of the bleeding coming from the lesion as well. So on autofluorescence, you can see that there's I think autofluorescence always nicely shows if there's an associated either shallow retinal detachment or more prominent retinal detachment. In this case, the associated exudative retinal detachment was, of course, visible clinically as well. This is the ultrasound of this lesion, so you can see the mass that shows low reflectivity with the localized Brooks membrane, as I said, and the associated detachment. So we diagnosed this as a choroidal melanoma and planned a plaque treatment. We treat with iodine 125. Here at Bascom Palmer, as well as a fine needle aspiration biopsy, which we always do in our patients for prognostication, so for gene expression profile and next generation sequencing. Unfortunately, the patient developed a pneumothorax and was subsequently hospitalized and lost to follow-up for quite a long time. Now, the patient comes back 5 months later, and you can see that the appearance of the eye is much different. Now, the patient has light perception. He has severe pain in the right eye. So the eye is inflamed. You can see a close-up of the photo here where there's like some eyelid edema, some conjunctival chemosis, and the IOP is very high. Now, this has progressed to a total retinal detachment, and you can see how significantly the mass has grown. Not only that, but there's some subtenon edema and some T signs, so likely a component of posterior scleritis as well, which is explaining some of the inflammatory signs and symptoms that we can see in this patient. He unfortunately ended up having to undergo enucleation, and the specimen confirmed the diagnosis of choroidal melanoma with extensive necrosis. Moving on to another case, this was a 59-year-old man with 1 week of metamorphopsia in the left eye and a dull headache. He also had an diffuse episcleral hyperemia. So you can see that there is a mass, mixed pigment mass, I would say, in the superotemporal mid-periphery, but you can also see that there are elevations peripherally as well. And so the question here, are these multiple masses or is this something else? Based on the radial folds, this is a little bit more suggestive of choroidal effusion, and you can see it as well on autofluorescence here. And as a matter of fact, when you get a B scan, it is confirmed that the supratemporal lesion is a solid lesion, while the peripheral quote unquote lesions are actually choroidal effusion. So the next steps here would be if there's any concern that this represents a metastasis, to get systemic imaging. Whenever there's a mixed pigment lesion, we always have to consider, of course, a melanocytic lesion. And so the options would be to either biopsy this first or go straight to treatment with brachytherapy. The systemic imaging was negative, so we decided to proceed with FNAB first, and this confirmed the diagnosis of a spindle cell melanoma, again with extensive necrosis. So when it comes to the relationship between inflammation and uveal melanoma, this is quite uncommon. The presentation of uveal melanoma is typically painless. Patients can be symptomatic with metamorphopsia as well as photopsia or visual field defects, but usually they don't report inflammatory symptoms, they don't report redness, they don't report pain. So scleritis and episcleritis are quite rare, but they're definitely more commonly reported in necrotic tumors. Choroidal detachments are also exceedingly rare. And in the largest reported series, which is 6 cases, 5 cases were choroidal metastasis and 1 case was a melanoma. Uveitis is even more rare when it comes to these lesions, but it has been reported as panophthalmitis or endophthalmitis in uveal melanoma, as well as sometimes there's a presentation of sympathetic ophthalmia, either in treated or untreated melanomas with extraocular extension. And we've actually recently had a case of that here somewhat recently. So this was a series of 157 totally necrotic tumors, choroidal and ciliachoroidal melanoma specifically. And so 75% of these had evidence of episcleritis and scleritis. So you can see how much more common and how much more frequent it is to have this kind of inflammatory manifestation if the tumors are necrotic, versus the only 5% had evidence of episcleritis in the non-necrotic ones. These are other series that I've reported on this relatively rare entity. And one thing that was shown in one of these papers is that the necrotic melanomas have a longer time to enucleation and more likely can present secondary glaucoma, inflammatory exophthalmos, as well as extraocular extension. So in a more recent paper that was published in Ocular Oncology and Pathology in 2014, the postulated mechanism is that spontaneous necrosis is secondary to tumor hypoxia. So pretty much the tumor cells replicating and the tumor increasing in size pretty much outgrows its blood supply. This causes necrosis, and this is followed secondarily by inflammation. So moving on to another case, this was a 63-year-old woman that presented with, again, some inflammatory symptoms, mostly a headache, painful and inflamed right eye. She had eyelid edema and chemosis. She was seen elsewhere on the outside, and she was started on tobramycin and dexamethasone. And then there was some concern about potentially preseptal cellulitis, and so she was started on antibiotics as well. So a few days later, the chemosis improved, but the patient developed diplopia and limited motion and limited motility in all gazes. So there was a concern about potentially orbital inflammation. She was started on prednisone 40 milligram, and an MRI was obtained. And you can see here that there's a large mass with a small intraocular component and a much larger intraocular component. And the thickness was measured at 14 millimeters total. When you look inside the eye, you see that the smaller intraocular component is actually pigmented, and the OCTs shows that the lesion is in fact choroidal, and you can see on B scan the big difference between the smaller intraocular and the way larger extraocular component. Systemic imaging was negative for metastatic disease, so our working diagnosis was that of a choroidal melanoma with significant extraocular extension. This tends to be quite rare, so usually the areas of extraocular extensions are not as extensive. So the patient was referred to the oculoplastic service for a modified enucleation plus or minus orbital radiation versus exenteration. She was seen by radiation oncology, and so the pros and cons of orbital radiation were further discussed. In the meantime, though, radiation oncology decided to repeat the MRI, and they noticed that the thickness of the lesion had decreased significantly. It was now down to 8 millimeters from the originally measured 14 millimeters. So this reduction in size post-prednisone was interpreted by radiation oncologists as suggestive of lymphoma, even though we were definitely not convinced about this because the lesion was pigmented. So the patient wished to avoid invasive surgery and went ahead with EBRT, which was prescribed at a dose for lymphoma, so 30 grays. In the meantime, thankfully, we were able to obtain fine needle aspiration biopsy. Cytopathology was inconclusive, but the gene expression profile, the next generation sequencing, actually showed mutations that are typical for uveal melanoma. So the diagnosis was confirmed, and the patient ended up being enucleated, and pathology actually confirmed that the extraocular extension portion had significant necrosis once again in the center, and you see just a close-up of this. So while again it's very rare, orbital cellulitis can be the initial presentation of melanomas or tumors that have a significant extraocular component, again, with necrosis. So finally, this is just to show that this is not unique to uveal melanomas. This was a patient, a 71-year-old man, again with severe pain, some scleral inflammation that had a past medical history of a lung transplant. Here you see the mass, higher reflectivity, so more concerning for metastasis. And when we do systemic imaging, as a matter of fact, the patient did have a lung mass, which was missed on previous or not present on previous scans that he got for his pulmonary condition, with multiple metastases pretty much all over the body, unfortunately. Fine needle aspiration biopsy confirmed presence of epithelioid cells, again with extensive necrosis consistent with non-small cell carcinoma. So while inflammatory manifestations of intraocular tumors are not common, they can certainly occur in necrotic tumors, and they can be quite atypical. They can include pain, episcleritis and scleritis, choroidal effusion, more rarely uveitis. If you have extraocular extension with necrosis, that can even lead to orbital manifestations. The apparent decrease in size of tumors, like it happened in the third case that I showed, can actually be due to the reduction in inflammation. So sometimes, the mass is kind of the size of the mass can be overestimated if there's a significant inflammatory component. So what happened in the third case is that this was interpreted as a reduction in size of the mass, suggestive of lymphoma, but it was in fact just the inflammatory component that was treated with the steroids. So this, as I said, is quite rare, but it can happen in a number of cases. So it's nice to keep it in mind. Thank you so much for your attention, and I'm happy to take any questions or discuss if there's any questions.
Yeah. Thank you, Doctor. I think it was a very illuminating talk. So, Dr. Mayur, any thoughts on our talk? Do we have Dr. Mayur?
Excellent talk, especially the fact that the steroids actually caused a reduction in the size, and that's what led everyone to believe that probably it was lymphoma. But it's great that we could have a diagnosis with the fine needle aspiration. So very, very actually, as you said, an illuminating talk.
Yeah.
Love to learn
Thank you so
from
much.
this.
Yeah, that was one of those situations where we're actually able to leverage the presence of specific mutations because, it was a small intraocular component, so there wasn't a lot of sample to just go by in terms of cytopathology. But those typical mutations, the G protein mutation, so GNA11, GNAQ, and a secondary downstream mutation, in this case, the SF3B1 mutations, they've been described as pretty distinctive of the uveal melanoma landscape. So it was a nice way to be able to leverage this kind of technology for sure. Thank you.
Thank you.
Thank you so much, Dr. Nicola. So,
Maura,
Yes.
Maura, how are you?
Good. How are you?
Excellent presentation.
Thank you.
I understood you said that inflammation probably comes from a tumor ischemia. So what could you tell us about the use of anti-angiogenic in ocular solid tumors?
Yeah, that's an excellent question. And I think there have been a number of situations in which intravitreal injections of anti-VEGF has been tried to see if it can, in a way, even potentially, change in some way or modify or impact the vascular supply of the tumor and even potentially lead to shrinking. We know that, Avastin is used in colon cancer a lot, right? That's how kind of like it was discovered for intraocular use. There hasn't been any convincing evidence that routinely using anti-VEGF for intraocular tumors leads to any real significant impact on the size of the tumor. So it's not routinely used while it's been tried, it's not routinely used for neoadjuvant treatment. It's certainly used, or personally, I use it not only for treatment, but also for prophylaxis of radiation side effects, such as radiation retinopathy, maculopathy, or papillopathy. So I routinely do that after my plaques, especially if the lesions are very posterior, close to the optic nerve, close to the macula, but no convincing evidence that really it impacts the tumors, and not all tumors have an extensive necrotic component. They usually are the larger ones, the ones that unfortunately have been kind of whose care has been delayed, that have been a little bit more like that, in my experience.
Thank you.
Thank you so much.
Thank you so much. Yeah, Prabjot, you can.
Yeah. So I think moving on to our next speaker, that's Dr. Mohit Dogra. We are excited to have you with us on board. Dr. Dogra is currently serving as an associate professor in the PGI Mer Chandigarh, which is one of the leading institutions in ophthalmic care and research. He's a highly respected vitreoretinal surgeon with a special interest in uveitis. Over to you, Dr. Dogra.
Thank you, ma'am. Thank you for the kind introduction, and thank you to Dr. Weber and the entire team behind Pan Ophthalmologica 2025 for this kind invitation and this opportunity. I'm quickly going to get on to it. Can you see my slides, and am I audible, please?
Yes, yes.
Yeah, thank you. Thank you. So I'm going to be speaking on cyclitic membrane dissection for managing uveitic hypotony, and particularly, look at a scenario of pediatric uveitic hypotony, generally in the setting of juvenile chronic or idiopathic arthritis. Yes. So when we look at uveitic hypotony, it could happen in the acute setting, when the eye is so-called hot, which could be, de novo acute or like acute on chronic, or it could happen in a more chronic setting. So the acute one would be, when there is typically like a, ciliary body shutdown, as they say, which typically happens because there is so much of this, just such extensive breakdown of the blood aqueous barrier and such outpouring of proteins and fibrin in the anterior chamber that the ciliary body, which is part of the uvea, actually gets a shock and kind of decreases production. And so it's a transient low pressure, and that's why a lot of these really acute anterior uveitis, typically HLA-B27, if you were to do the pressures when the eye is really hot early on in the attack, the pressures would be about 8, 10, 12, not typically hypotony, but low. You could also have supraciliary fluid, which is just that the ciliary body per se is okay, but due to inflammation or due to a peripheral choroidal detachment or choroidal effusion, there is seepage of some fluid underneath the ciliary body as well, which also causes low pressures if the ciliary body is not anteriorly rotated, causing high pressures. Or there could be ciliochoroidal detachment, which could be, again, it's like the chicken and egg story. Hypotony brings ciliochoroidal detachment, as ciliary choroidal detachment can also lead to hypotony. So certain uveitic entities like BKH can primarily present with peripheral ciliochoroidal detachments. Certain drugs that we use for VKH can also cause it. Certain non-uveitic drugs, typically some antipsychotics, can also cause some ciliochoroidal detachments, which can cause both low and high pressures depending on how much the pressures, how much the supraciliary fluid and detachment is there. Why it's important to differentiate acute from chronic is that in the acute phase, there is hardly any scope. I'd say there is absolutely no role of any surgical management. You have to treat the attack, right? You want to kind of douse the fire which is in the eye. So you want to treat with, go all guns blazing, topical, systemic, maybe periocular, depending on what the uveitic entity is, steroids, along with cycloplegics. And for the most part, if you're able to, kind of douse the flames, these things will take care of itself and the pressures will build up. The issue is the second part, which is the chronic hypotony, in which either there have been multiple attacks going on, which the patients ignored, Or, in kids, particularly, the attacks are not known because it's a white eye. Kids will typically not complain, and they will typically only land up when the vision is compromised, either because of a white eye or poor performance at school, and they have complications of complicated cataracts, BSKs, and all of that. And in those, the causes of hypotony, because of repeated insults, are atrophy of the ciliary processes and oblique, combined with cyclitic membrane. So I'm going to be particularly talking about the cyclitic membrane chronic component. Now, if there is one imaging, and by all means, and I'll say this with folded hands, but with a firm tone, if you do not have access to a high quality UBM, please do not try and manage these patients. Chronic hypotony, UBM is a must. And why it's a must? It's not just limited to these 3 points, but these 3 points are the most critical. You want to take a look at the ciliary body. Since you're looking at hypotony, so the factory, the production house, which is the ciliary body. So you want to look at whether it is atrophic or not, how many quadrants, whether it's detached or not, how many quadrants, whether there's presence or absence of ciliary fluid. Also, you want to look at whether, along with all of these things, there is presence or absence of cyclitic membranes, and in how many quadrants. And based on that, you want to try and determine A, whether you want to do surgery, B, if surgery is indicated, do you want to enter through the limbus, or you want to enter through the anterior pars plana? Because if it's a very thick ciliary, cyclitic membrane all around, and there is no clock hour that you could see is typically free in the UBM, you will burn your hands, and that eye is almost lost if you try and enter through the pars plana, because there is no demarcation of where the aura finishes and the cyclitic membrane begins. So even if you enter 2.5 millimeters posterior to the limbus in those eyes, you will go through the retina, which is pulled up, and cause a giant retinal dialysis in the periphery, which is almost like a death sentence for that eye. So those eyes, based on the UBM, you decide limbal or pars plana, and if pars plana, which clock hours you want to make your sclerotomies, based on which are free from the cyclitic membrane. And this is what you typically would want to see on a UBM. This is ideal. This is a normal patient. You can see those ciliary processes. If you see that, that's great. No cyclitic membrane. That's what you ideally want to see. Unfortunately, in hypotonic eyes, that's the holy grail, which we don't get. We get the upper right, which is that cyclitic membrane, and you can see that below those finger-like projections are not seen. So it's ciliary body atrophy with the cyclitic membrane. And you can also get, in certain cases which are more acute, just a swelling, a thickening of the ciliary body, which is a marker of chronic hypotony happening. And you could also get this, which is supraciliary fluid, as you can see there. So both of the bottom ones are suggestive of more acute process, which do not require surgical intervention and just treating the underlying uveitis. The upper right, however, is something that we need to tackle surgically and remove this. I have a video here which is going to be playing, and it has
this video, we discuss the role of cyclitic membrane removal in the management of chronic hypotony in pediatric uveitic eyes. Hypotony resulting from ocular inflammation can occur in both acute and chronic phase of the disease. Chronic uveitis can lead to development of cyclitic membranes, which not only increase but also decrease secretion by directly damaging the ciliary epithelium. We demonstrate the preoperative evaluation and surgical technique for management of such chronic uveitic eyes. This 7-year-old female child was a known case of juvenile idiopathic arthritis with counting fingers vision in both eyes and intraocular pressures less than 6 millimeters of mercury for the last 6 months. She was on immunosuppression. A visual rehabilitation was planned, keeping in mind the complicated cataract and the associated hypotony. Ultrasound biomicroscopy played the key role in this case by demonstrating the presence of cyclitic membrane and ciliary body atrophy, which warranted cyclitic membrane removal with silicone oil tamponade. 25-gauge pars plana vitrectomy ports were made and iris hooks were applied to achieve adequate pupillary dilatation. Infusion was switched on after viewing the cannula. Lensectomy was completed with meticulous removal of the lens matter and lens capsule. Complete vitrectomy, including triamcinolone assisted posterior hyaloid removal, was done. Careful cyclitic membrane removal was done 360-degree under direct view of the microscope. Peripheral scleral depression was used to visualize the ciliary body area. The membrane was slowly segmented into smaller parts with the help of intraocular scissors in all the quadrants, followed by removal with the vitreous cutter. Care should be taken to prevent direct injury or excessive pull to the ciliary processes. Silicone oil tamponade was given at the end of surgery. The patient achieved a visual acuity of 6 by 12 and 618 with aphakic glasses with intraocular pressures of 14 and 16 millimeters of mercury in the right and left eye respectively at 1 year after the procedure. To conclude, manage
Yeah, I'm just gonna finish with one.
this.
Sorry, with one slide, which is the last one. And so, if you were to look at the nuances of this surgery, I think what's a given is that meticulous total lens and capsule removal needs to be done. You need to apply hooks, get the pupil up big, and do not leave. These eyes have very low tolerance for any remnant cortical matter or lens. So you have to remove each and every last shred of it. Ensure that you do a complete triamcinolone assisted posterior hyaloid removal. The objective is to dissect the cyclitic membrane from about ideally two quadrants, which is about 180 degrees, if not a quadrant and a half. If you're able to free that much amount of ciliary body, that's good enough for the eye to be able to mount amount of pressure and not go into phthisis. The idea is not to pull on the membrane. This is not like PVR, retinal detachment surgery, where the retina you can actually go and pull. You pull those membranes, you will cause a giant ciliary body slash retinal dialysis with extensive torrential bleed and lose the eye. If you're able to free 1.5 to 2 quadrants of ciliary body and the underlying ciliary processes are visible, then there is no need for silicone oil and you can leave these eyes as such and they do fairly well. However, if despite your efforts, the cyclitic membranes are like cement and they are plastered to the ciliary epithelium, then instead of removing them, you want to trim it down. And if despite all of that, only one or less than one quadrant of ciliary body is what you could free, then those eyes are almost silicone oil dependent eyes. They need 5,000 centistroke silicone oil. And a word of caution, just my last point regarding this presentation, the poor prognostic signs are if you see iris or lens neovascularization at the get-go, these eyes they typically have BSK, but if you have widespread corneal changes like corneal haze, which is beyond the BSK, or lipoid keratopathy, which is lipid deposition, which is in different parts of the cornea, if the UBM shows 360-degree atrophy and with a very thick cyclitic membrane in all quadrants, or if the hypotony is so severe that there is inward dimpling of the cornea, almost like a concavity, I think those eyes are almost best left alone and typically will not do well. Apart from those, other eyes with meticulous planning, I think, can be subjected to this surgery with gratifying outcomes. Thank you.
Thank you very much, Dr. Dogra. It was an amazing talk, and I think the questions which I had for you, you already answered them in the last 2 minutes. So I wanted to understand what are your how do you prognosticate these cases? But yes, very clear answers. Thank you so much once again for joining us here. And I think with this, it's 6 p.m. and we'll continue to be on time. And I'll hand over the session to the next moderators, Dr. Sumit, Randhir Singh and team. Thank you very much, everyone.
Thank you. Thank you.
Am I audible, everyone?
Yes. Yes, you are.
So hello, everyone. On behalf of Pan Ophthalmologica 2025, I would like to welcome you all. And we have a special international webinar today. And currently we are in session 2 in Hall C. So the first talk of the session is going to be by Dr. Gerardo Garcia from Mexico. So Dr. Garcia is an attending physician in the retina department at Association for the Prevention of Blindness in Mexico. And he has more than 40 publications in peer-reviewed journals, more than 30 book chapters, and he's editor of more than 4 books. He has been an assistant editor for the Mexican Journal of Ophthalmology since 2017. He is a certified physician by the Mexican Board of Ophthalmology, and he's a member of Mexican Society of Ophthalmology, ARVO, ASRS, and the Mexican Retinal Association. He has served on the board of the Mexican Retinal Association as secretary, treasurer, as well as president. So over to you, Dr. Garcia.
Good evening, everyone, and thank you very much for this very kind invitation. I will share my screen now. Okay. Can you let me know if you can see my slides? Good. So this is what I think is an interesting topic that I wanted to bring up, which is retinal tears and skydiving, and if these patients should actually jump if they do have retinal tear. So this case presented to me a few years ago, and it is a 53-year-old male. He had some years prior, he had myopic LASIK of around 4 diopters. And 2 weeks before presentation, he presented with floaters in the left eye. His visual acuity was good. He was 125 +2. The anterior segment was within normal limits. And he had a mild vitreous hemorrhage. As you can see there, the vitreous opacities, especially in the inferior vitreous. And this was August 11, 2022. And in the superior retina, he had a large horseshoe tear with some subretinal fluid in the supranasal quadrant, and he also had a torn lattice degeneration in the superior temporal quadrant. And so he was lasered in both tears, as you can see there. And at the end of the visit, after we had applied the laser, he told me, quick question. Can I skydive? And turns out that he's very, very passionate about skydiving. That is a picture of him, making this huge, like star structures when skydiving. And he told me, I am signed up for this 200 people star to break a world record. And this was going to take place 11 days after I applied laser in August 22. So the question that he asked me is, can I do this? Can I jump? I've been preparing, for this for a couple of years now. And I wanted to, make a pause here and ask you guys in the distinguished panel if you think that he should jump.
I would vote no.
You would vote no. So do we have any other opinion from the very distinguished panel?
I think he can jump.
You
I
think
say
he
yes.
can? Okay, Mario, yes. Well, Mario, you're very relaxed, so.
Yeah, I'm sorry. That's my way.
So I spoke with the patient, I talked to him about what are the pros and cons, and that theoretically laser burns do create adhesion 7 to 9 days after application. And I took a dive in the literature, and actually there's not a lot about this topic. So this is, if you go to the American Academy of Ophthalmology website, you can find some questions like these that are answered by experts. And so this patient asked if he could skydive with lattice degeneration, and the answer was that there should not be an increased risk of tear or detachment. And these other question where the patient asked if he or she should avoid something after or during a posterior vitreous detachment, and within the answer there is that there's the indication to avoid activities such as skydiving, bungee jumping, or bumper car rides. But there is not a lot about retinal detachment and skydiving, and the ones that have published most about this topic are people from Scandinavia. Apparently, they do a lot of skydiving, so they do have a very, since it has a bad rap of being a dangerous sport. Justifiably, I think, but they do have a very, very meticulous registration on the injuries caused by skydiving. And for example, this paper that tracked skydiving injuries from 1999 to 2003, including over 500,000 jumps. Sorry, and they reported 257 injuries. Or 0.047%, which is around the risk of endophthalmitis after a cataract surgery, for example. And here you can see they subdivide the injuries according to the timing of the jump. So as you can see, in an aircraft exit or free fall or parachute opening, the amount of injuries are a lot less than at landing. And as you can see, the landing has the most of them, including this 53 lesions were landing off the drop zone, which I really think that's where the danger is. But us as retina specialists, I think the most concerning aspect would be parachute opening, which is when the body is subjected to most gravitational force or centrifugal force. And actually, as you can see, less than 10% of the injuries were observed during parachute opening. Now, this is a subdivision of the part of the body that was hurt, during this act. As you can see, in the head and in the face, there had been fractures and concussions, but there is not a single case of a retinal detachment or retinal tear published in this paper or anywhere in the literature actually that I could find. So now, what happened to the patient? After I gave him all this speech about risk and benefit of doing this, he actually went through the jump, and this is as you can see. This is a time where he jumped, and they formed this star, like human star, in the air. And they are subjected to I think it's 300 kilometers an hour when they're free falling, going towards each other. And then this is a video during the parachute open, as you can see there. Now they don't do this just one time. This is just one try. Along 3 days, they do this like maybe 10 or 15 times. So I told the patient, okay, if you're gonna do it, just come back and see me after the jumps, just to make sure that everything is all right. And sure enough, as you can see, 2 weeks after the jumps, the laser scars are there. There wasn't a single problem, no additional lesions, and no problems from the lesions that were previously treated. So in conclusion, I think injury after skydiving is rare, and I mean injury in general, occurring mostly when landing, as we could see. And so far, no ocular or retinal complications have been reported in the literature during or after skydiving. And I think it's more our preconception that it's a dangerous sport and that patients should avoid these very high G forces. But in reality, that has nothing to do with an actual or true risk of complication. So so far, I think there is no evidence to suggest that patients with treated retinal tears should avoid skydiving. And that is all. I would love to hear your comments.
So thanks for that interesting case. So I just had one question, like the literature review, what you showed, like these were the patients who had lattice degeneration. So there probably it's like much common in the general population as well. So this patient like lasered 11 days ago. Suppose this patient had some sort of subclinical retinal detachment, 1 to 2 disc diameter of subretinal fluid around the brain. So would you have advised similarly, or suppose this patient had subretinal fluid inferiorly? So would your opinion have changed, or would you have continued the same advice?
No, I mean the supranasal tear did actually have subretinal fluid around it, so it was a subclinical retinal detachment. And I think if the laser barrier is applied properly, then your risk would be no different from just having a small tear. Obviously, if there were untreated lesions, I would advise against doing the jump.
Actually, the point is, excellent case, Jerry.
Thank you.
Always love your presentation. But of course, we are not talking about skydiving patients because we are not going to have too many of them. But what you are propose us to think about is when do we think doing anything would be safe a few days after a laser, and making a reduction of this question is how long does it take for a laser to do apexia? And it seems like, I don't know why we say 10 days, 1 week, or 9 or 11 or 15, because actually there are many studies on actually few days, even hours after the laser, you can get some apexia, and about 3 or 4 days after laser, you got most of the adhesion that you can get 10 days or 2 weeks later. So laser is a very fast apexia. Not that fast is the prior, but I think that this is what we are discussing about. I don't know what you think.
So what I teach fellows is actually, from the retinal detachment book from Ron Michaels, and there's a whole appendix in chapter 7 that talks about all these chorioretinal adhesion methods and the experiments that were done, and they were not done in humans. Obviously, they're done in animals. You achieve around 200% of the adhesion of the retina to the RPE around day 7. So for me, that is like the conventional wisdom that you should wait at least 1 week, to achieve full adhesion. And after that, I do see a lot of my colleagues, some of them even retina specialists, prohibiting patients from, like doing yoga, getting heads up, or dancing, or a lot of stuff that they love, just because this, I think it's a wrong misconception. A misconception that it is unsafe to do all those things because of the risk of retinal detachment.
Agree.
Thanks for the interesting discussion. Now we'll move on to the next talk. I'll hand over to Dr. Malvika Singh.
Okay. Good day, everyone. So I'll be introducing our next speaker, Dr. Giuseppe Querques. He's a noted ophthalmologist and researcher, especially renowned for his work in medical retina and macular diseases. He is an associate professor at the Vita Salute San Raffaele University and heads the medical retina and imaging unit at the IRCCS in Milan. He is particularly skilled in advanced ocular imaging techniques, diagnostics, and treatment of retinal and macular disorders. He has many notable honors, including the Young Investigator Award from the Macular Society in 2019. He has published nearly 800 scientific papers, serves on multiple editorial boards, and has earned significant international recognition. I now invite him to deliver his talk.
Is he available with us? I think. Let me just share his presentation. Can you see the video playing?
No, just your Windows.
Okay,
just the window where the files are.
Is the video playing now?
Yes. No, I hear no audio.
Is the audio playing? Is the audio playing? Everybody can hear the audio?
I cannot. I don't know about the rest.
No, the audio is mute.
We have the tech team here. I can play the video, but is the audio playing now?
No, not that I can hear.
Dr. Malvika, do you have the contact of the tech person?
Sir, I'll check.
Yeah, I think it's a great idea. We can move on to the next talk by the time the tech team sorts it out. Dr. Devendra?
Hi everyone. So, okay, we'll move on to the next talk. It's my great pleasure to invite Dr. Mario Saravia. He's the research director at Buenos Aires Macula and a prolific researcher and currently developing a very fascinating nanomagnetic tamponade for retinal detachment, though that's not the topic for his talk today. I invite him to start his presentation on ophthalmic artery angioplasty for treating geographic atrophy. Welcome, Dr. Mario.
Hey, thank you. I cannot share my screen until you stop sharing the other one. Okay. Do you hear me?
Yes, sir. Please go ahead.
Yeah, you're audible.
And you can see, and you can see my screen. Okay.
No, we're not able to see your slides.
Okay. I don't know what's wrong with it.
Yeah, now I think it's starting. Yeah.
Okay. Just tell me when you are seeing me.
Yeah, perfect. It's
okay.
visible now.
Well, I'm going to talk about ophthalmic artery angioplasty for GA treatment. And it sounds a little invasive for us. We are not used to hear about, we are used to approach to the eye from the front, but not from the back. That is what we are doing. So in the first slides, I'm going to introduce you to the basics of why we are doing this. And this is the question that I'm trying to pose. Of course, this is something that could sound a little Copernican for all of us, but I am pretty convinced that this is something that we have to start to think. The point is that we have this couple of pretty sympathetic cells, the photoreceptor and the RPE cell, and those cells it has the highest consumption of oxygen in the body. 10 milliliters per 100 grams per minute. That is almost double the consumption of oxygen of the brain. And happens to be that we have this particular high consumption exactly over an area that we call fovea, and it is avascular. So how come we can manage this? The only way to find a balance on this is having a very, very high perfusion with excessive supply of oxygen from the back. And that is, we all know, the high perfusion we have in the choroid. But maybe not too many of you know that 1,400 milliliters per 100 grams per minute is like 4 times the renal cortex flux. So it is really high, and it is the most important perfusion site spot in the body. So this is why we are following this guy's idea. Like 50 years ago, he was saying that the macular region is especially vulnerable to chronic ischemic disorders, but actually to perfusion disorder. And he based this in the watershed zones. What is this? Well, the little arteries that penetrate from behind the macula enters the eye, and they spread like in a fan, centrifugally, supplying with irrigation for well-demarcated zones that works very, very, very well to cover the oxygenation of the macula if the perfusion is high. But if you have low perfusion, the area that is more vulnerable in this higher proposal is the macula, and it's true. So it's an area at risk, and it works perfectly if you have the highest perfusion rates. But if you have something like a little occlusion, and let's say a 50% occlusion of an artery that, for instance, in a coronary artery wouldn't make any difference, because there are big arteries. In small arteries, by Poiseuille law, you can reduce the flux 16 times. That's a lot. So that's why we thought it wasn't a bad idea to change that situation in patients with GA. And we could demonstrate in an unpublished work that 100% of the patients with GA had an occlusion. 100% of cadaveric specimens with GA were found to have occlusion in the ophthalmic artery. So this work is made only in Argentina for the moment, with the collaboration of Phil Roosevelt in Bascom Palmer. It's a neurosurgeon and interventionist who makes the procedure, and a lot of retinologists are participating in this project. This is a special catheter we use to do this procedure. As you can see, there is one of them in the right is a guide that has like an anchor, and the other one is the balloon that once we find the way the spot where the artery is occluded, you can insufflate the balloon. And we really changed the perfusion status of every patient. This is one of the patients. This is a special software where we can make the flux, and you can see how this artery recovers the laminar flux. But it's better if you see in this short video. In the left, you are seeing a patient during a cerebral angiography, and the yellow circle shows the place where the eye is supposed to be. After the angioplasty, I mean, This second video in the right is 15 minutes after the angioplasty, and you will see how the eye recovers a lot of perfusion so that you can see it clearly. So let me check. Okay, so what happened once we did this? We did this in 11 patients. What were our results? Well, patients increase macular choroidal thickness in a statistically significant way, as you can see in the right scheme. The orange line is the fellow eye, so fellow eye didn't change, and study eye changed a lot. And our patients recovered 7 letters. 7 letters in patients with an geographic atrophy of about a diameter about 12 millimeters. So very important atrophy. They started to fix with the center. We don't understand why. Still, we don't have an answer for that. But these are, as you can see, compared to the fellow eye, of course, fellow eye didn't recover any vision. Also, well, and I don't have the slide, but in our patients, they improve reading speed, the Minnesota reading speed. So this is something that is really changing the way the retina, the macula is functioning, supplying more perfusion. So our question is AMD a vascular disease? Can we say that AMD is a genetic disease with some vascular component? Or maybe we have to think that it is a vascular disease with some genetic predisposition. Well, this is my point for your discussion. Hey, okay. So weird that you're all muted.
So, Maestro Mario, I always admire that you are thinking outside the box, and I think that's wonderful because sometimes that is the way that great improvements and breakthroughs are made. Now, I know for a fact, because I have seen your presentation before, that you have faced a lot of resistance regarding this concept, because it's so very maybe we as ophthalmologists we're pretty scared of doing this very invasive maneuver to the ophthalmic arteries and whatnot, and so it becomes a matter of extraordinary claims require extraordinary evidence for people to believe you, right? Now, have you done microperimetry in these patients, to document any improvement?
Yes, we have done. I didn't show it because it wasn't in the original protocol, but I measure microperimetry in study patients just like a collateral and a personal evaluation, and it was amazing because patients at the beginning, before the procedure, patients were fixing in the margins of the atrophy area, and after not all of them, but some patients moved the fixation point from the margins to the center of the atrophy. That is something crazy because we are used to think that every neuron that it's above the atrophic area, it's there, and I think that probably what we are having is that probably the body of the photoreceptors are taking some oxygen from the superficial network of vascular, and probably they survive and they stay like dormant. But in a way, because it is very consistent. And I'm so sorry I stopped sharing my screen, but I could look for it to show you. It's amazing. There is something that it's very, very shocking in our patients. Of course, we did this procedure under anesthesia, and patients, they don't know each other, they don't have any contact in between them. 100% of the patients, as soon as they wake up from the anesthesia, they say, hey, whoa, I'm seeing better. At the beginning we thought it was a placebo effect, but it was consistent. And of course, sometimes we didn't find a huge, because this gaining of 7 letters is an average. So there are some patients that gain 2 or 3 letters and some others that gain like 15 letters. But in those patients that they gain few letters, still they say in a very consistent way, they say, I'm seeing better. Well, what is the point? They say, oh, now I see, now I walk in the street, in my street, and I see the group of the trees. So they give us like the impression that they are improving more functions than we were measuring, like visual field or contrast or color. We don't know. So, but this is just, as you said, and you nailed it. How did you say? Challenging claims need a lot
extraordinary claims.
Extraordinary claims. Yeah. And I agree with you. We are on the way. This is the first study, and we are going to start a new one close, maybe next year.
I'd like to congratulate my 2 big friends in life, Mario and Gerardo. Big talks, and really was in this Mario idea since the beginning. Remember, we are discussing this in Dubai 2 years ago when they're just beginning.
Exactly.
You just beginning the idea. And this year I had a very good discussion with Anita Gawa about dry AMD, and she said that gas hypothesis about GA is vascular. Gas thought that the only way to improve really the GA is trying to get better oxygen flux in the choroid, and I think you are persuaded in the right way, and I believe that's the result will come. By the way, do you have any OCT that shows any change in the AZ line, I mean photoreceptor line? That's because nowadays everybody is looking more about the photoreceptor because it's the one that first died during the GA process, and I don't know if has any change when you improve your vascular flux in the choroid.
Yes, well, actually, we didn't find substantial change in the OCT, and we cannot explain why we have this improving in function. You need to understand that we weren't looking for any change in function. Actually, it was a surprise for us. This was just a safety work, just a few tries, but we found this. So now we are trying to understand, of course, in the next phase, we are going to make a more deep assessment. But answering to your question, no, we didn't find in the OCT significant changes. Maybe we think that probably these patients have only like scattering few neurons that could survive, and maybe something is that they are awakening after a new supply of oxygen. But it's difficult to understand because they don't have RPE cells behind them. So we all know that you need the couple to make a full vision function. So we need to understand a lot more. We are just showing you what we found.
Can I ask a question, Mario? Hi, this is Ihab from Egypt.
Yes, of course. Hey, how are you?
I'm good. How are you?
Good to see
Thank you
you.
for putting us all together. Thinking the way about the vascular theory, would this be possible to do like a vortex ligation? 2 or 3 vortices. We know that we can sacrifice up to 3 vortices. So by increasing the flow, I can dilate an artery or occlude a vein. If you think about it. So the question to you is, if we occlude 2 superior vortices or 2 or 3 vortices, would this have a same effect on kind of increasing the flow? This is my first question to you. And I have a comment about also for your next trial, which I find amazing because we do the ophthalmic artery catheterization for retinoblastoma. So I'm familiar with the region and I see what the neuroradiologists do. There is new machines that consistently measure the choroidal thickness. The BMSR and the Chinese companies that are launching amazing machines that can...
Yes, Intalide and RPI.
Yes, they measure the choroidal thickness and give you numbers, actually. So whenever you're planning for a next thing, I think it will be hugely proof of principle to show changes in the choroidal thickness as it can be comparable and it is very consistent as well.
Yes, I will start for the last one. Yes, we are planning to use one of these systems. Still, I have my doubts, and I disagree a little with Phil Rosenfeld, who is part of this team, because he says, "Oh no, it's okay with these devices. We don't need to measure flux by any other means." But I think that even those new technologies, they just show you the structure of the choroid, but you are not seeing flux. Flux is flux, and you can calculate because you can suspect something about the flux seeing the size of the pipe, but actually you are not seeing the flux. So I don't know.
Yeah, it's a step.
Yes, I know because you can use Doppler system, but still it's a construction, but it's not real flux. Talking about the vortex, well, vortex veins actually what we are trying to do is to put all the pieces of this puzzle together. But if you go back to read how many authors said there is something wrong with perfusion in the macula in patients with AMD. It's incredible. From Alan Bird, Holtz, Christine Kurshaw, Tom Schuler, Martin Friedlander. Well, I don't know, but many thousands, not thousands, but hundreds. But they didn't say it's a perfusion thing. But the one who said there is something with the vortex veins was Ephraim Friedman in Harvard. And Friedman, he was like obsessed about that. Actually, I am thinking all the time about that, and I don't understand how come blocking or tying the vortex could change, because in some way what you expect to happen is that the flow decrease, not increase, if you stop the way out of the vortex veins. But tell
Sorry
me the
to
way you
interrupt.
understand this.
We are running short of time, so
If
probably
it's auto-regulated,
we can
but
move
I
on
don't
to
think
the
it's
next talk.
auto-regulated. Anyways, thank you.
Oh, okay.
Okay.
We have to keep on discussing this.
Yeah, we'll meet somewhere, I know.
Oh, yes.
Thank you very much for asking me to present on this important topic that is...
Is the audio playing now?
Yes.
Okay.
The double layer sign and foveal sparing GA. And these are my disclosure. And the topic is important because nowadays we have treatment for GA and many more are coming. But despite this, there's still high variability for GA progression and there's still a lot to understand and biomarkers to detect in order to better manage patients with GA and select patients for the different treatment for GA. We recently published on biomarkers precursors for GA development and their role in progression in terms of speed and direction. The biomarkers we were investigating were, in the end, the precursors for GA that are drusen, reticular pseudodrusen, drusenoid PD, and basal lamellary deposits. And patients were selected before development of GA and then followed from the development of GA and a year follow-up to look at the progression, so the expansion area, in terms of speed growth rate after square root transformation and direction of GA progression. These were the results of that study, and we demonstrated that the sole biomarker and precursor for high speed of GA progression as the presence of basal lamellary deposits, and in a sense, large drusen may be considered as protective for rapid progression. And the direction of progression was also very important to demonstrate in the study. That is, in case of basal lamellary deposits, more centripetal. This is extremely important if we consider that many patients with the foveal sparing in GA present what is a surrogate for basal lamellary deposits, that is the separation between the Brooks membrane and the retinal pigment epithelium. By looking at this characteristic that is also named double layer sign, Mani-Fuzzy group suggested that presence of this characteristic in foveal sparing is an important biomarker for progression. Unfortunately, this double layer sign may be thick or thin and differently representing the presence of MLB or simple basal laminar deposits And again, unfortunately, in the Amani-Fadi group study, there was no application of OCT angiography that is important to differentiate between the presence of a non-exudative MNV versus a simple basal laminar deposit. So we still don't know, despite the presence of a triple layer sign, if there is a real protective role and presence of non-exudative MNV versus basal laminar deposits in these cases with double layer sign in the foveal sparing. So this was the aim of our study. So we were looking into double layer sign because of thick basal laminar deposits versus non-exudative MNV by applying OCT angiography. And our hypothesis was that faster GA growth may be detected in cases of simple basal laminar deposits, and the slower GA expansion may be detected in cases of non-exudative MNV. These are the results. So the two groups were similar in the overall characteristics, including the area of foveal sparing. And when we looked at the thickness of the double layer sign, this was significantly thicker in cases with non-exudative MNV versus simple basal laminar deposits. But the most important result in our study was that despite an overall similar GA growth in the two groups, so non-exudative MNV versus basal laminar deposits, in the foveal sparing, in the area spared by GA, patients with non-exudative MNV did not change significantly versus basal laminar deposits patients. And this suggested a kind of protective role for the presence of non-exudative MNV in foveal sparing. So to conclude, OCTA is extremely important to differentiate basal laminar deposits versus non-exudative MNV in cases with the foveal sparing and the double layer sign. Presence of thick basal laminar deposits as an independent predictor for high GA growth versus a presence of non-exudative MNV that instead is somehow preventing GA progression toward the foveals. So as a way to guarantee foveal sparing over time. And this is probably because this new vessels non-exudative MNV is supplying nutrition to the residual RPE and outer retina right there in the fovea. Thank you very much for the attention.
Dr. Malvika?
Yes, sir. So thank you so much for sharing Dr. Quercus's video, his presentation. It was very illuminating about the disease progression in dry AMD. I would now invite any discussion from any of our esteemed panelists and other speakers.
If not, maybe we can move on to the next.
Move on.
Yeah, because
Yes,
we
sir.
have time.
Tewu from San Jose, Costa Rica. I would like to thank
Is
the
the audio
organizers
playing now?
of Pan Ophthalmologica for the kind
Yes,
invitation
sir.
to update
Yes.
you on macular telangiectasia type 2. These are my disclosures. Of note, I'm a consultant for Neurotech. I would like to start by summarizing my talk, the important points. I'd like to note that fundus autofluorescence detects early disease. Multimodality imaging and histopathologic correlations confirm Mueller cell involvement. MACTEL-2 is characterized by Mueller cell depletion, and MACTEL-2 is not a primary retinovascular disease. It is a primary neurodegenerative disease with secondary vascular involvement. MACTEL-2 patients have low serum levels of serine and elevated levels of deoxysphingolipids. Deoxysphingolipids disrupt mitochondrial function, and revakinagene tararetzel, or the CNTF implant, was recently approved by the US FDA for the treatment of macular telangiectasia type 2. So fundus autofluorescence is perhaps the earliest change that we see in patients with macular telangiectasia. Notice that in the normal eye, the exhibit a central dark area caused by the light absorption of the RPE melanin and the macular pigment. In contrast, eyes with MACTEL-2 lack that central dark area because of depletion of the Mueller cells, which happen to be reservoirs of the xanthophyll pigment. In confocal blue reflectance imaging that we obtain with the Heidelberg system with the blue light without any filters, you can see here that there's an increased confocal blue reflectance that topographically is related to areas of fundus fluorescein angiographic leakage, and you can see that this is a way of getting the diagnosis without doing an invasive fluorescein angiogram. OCT findings, you can see that here there's fluorescein leakage that does not correlate with retinal thickening, unlike other retinal vascular diseases, and the presence of these hyperreflective spaces are not related to retinal thickening. These hyperreflective spaces may represent cavity formation after photoreceptor or Mueller cell degeneration. These clinical findings have been confirmed on histopathology. Here is an eye of a patient with MACTEL-2 on postmortem, and notice that there is macular pigment absent in the center of the macula as observed in the fundus autofluorescence images. Histopathological immunohistochemistry with Mueller cell markers show loss of the Mueller cells, as you can see here. Furthermore, there's correlation between the areas of pigment depletion and the Mueller cell loss. We're going to switch gears here and talk about macular telangiectasia and serine. MACTEL-2 patients have low serum levels of serine and elevated levels of deoxysphingolipids. These elevated deoxysphingolipids casually are associated to macular telangiectasia 2, and the production and accumulation of these deoxysphingolipids are neurotoxic. This is illustrated by this study published in the New England Journal of Medicine, where 125 patients with MACTEL-2 demonstrated circulating deoxysphingolipid levels that were 85% higher than 94 unaffected controls. And these deoxysphingolipid levels were negatively correlated with serine levels. The importance of this is that the deoxysphingolipid disrupt mitochondrial function. The question is, why is the macula preferentially affected? One of the hypotheses is that the macula has unique metabolic demands that make them particularly vulnerable. However, this still needs to be further studied. We're going to switch gears and see what treatments have been developed over the years. And this preclinical study demonstrated that CNTF, or ciliary neurotrophic factor, showed efficacy in slowing photoreceptor degeneration in 13 different preclinical models. And the mechanism of this photoreceptor protection require activation of the GP130 receptor in Mueller cells. So the thinking was that CNTF could be a nonspecific neuroprotective treatment for diseases associated with Mueller cells or photoreceptor loss. This led Neurotech to develop this very innovative device, which is sutured to the pars plana, as you can see here. This device is very innovative in the sense that it holds living cells that produce CNTF, and the device here has little pores that allow the CNTF to diffuse out of the implant, but the pores are small enough that don't allow the cells of the immune system to get in there and destroy this factory of CNTF. It has been demonstrated that ANFAS maps of the ellipsoid zone are correlated with mesopic microperimetry, and the breaks in the EZ had a good correlation with retinal sensitivity loss. Also, there was good correlation between the EZ break area and functional loss, and the ANFAS OCT mapping of the EZ demonstrated structural change before mesopic microperimetry could detect a focal loss of retinal sensitivity. And because of that, the EZ area loss was accepted by the FDA as an endpoint in the clinical trials. Recent results from the phase 3 clinical trials demonstrate that the cell-based CNTF was effective for MACTEL-2. Some details from the studies demonstrated that visual acuity, reading speed, retinal sensitivity loss, and self-reported daily visual function were better in eyes treated with the CNTF implant, and the effect seemed to be greater in eyes that had a greater severity of disease. In addition, younger patients defined by less than 65 years and with less EZ area loss at baseline had less EZ loss in the treated eyes than in the sham eyes. So which this suggests that there might be an increased benefit in treating earlier disease. In addition, diabetic patients appear to have had less EZ loss when treated compared to sham. And curiously, Australian patients had less EZ loss compared to their US and European counterparts, which suggests that genetic or environmental factors may play a role on the responsiveness to the CNTF implant. Adverse events included delayed dark adaptation and meiosis. So in summary, fundus autofluorescence detects early disease. Multimodality imaging and histopathologic correlations confirm Mueller cell involvement. MACTEL-2 is characterized by Mueller cell depletion, and MACTEL-2 is not a primary retinal vascular disease. It is a primary neurodegenerative disease with secondary vascular involvement. MACTEL-2 patients have low serum levels of serine and elevated levels of deoxysphingolipids. Deoxysphingolipids disrupt mitochondrial function, and revakinagene tararetzel recently was approved by the FDA for the treatment of MACTEL-2. Thank you very much for your kind attention. Hi, this is Lee.
Interestingly, previously we used to consider the MACTEL as incurable disease, but at least with the CNTF implants, we do have some sort of treatment which is available. The only issue is the very high cost involved at present. We suppose that over time the cost should decrease, and at least some of the patients, especially in countries like India, should benefit from this treatment. We'll move on to the next topic now. Dr. Roca, if you can.
Hello, can you hear me?
Dr. Rohan Jan, if you can start moderating, please.
Hello, I welcome Dr. Hore Roca, who is a practicing retina surgeon. He is owner and president of iRetina Eye Institute. He is the board of director of Retina World Congress, and he is the first secretary of Brazilian Council of Ophthalmology. He served as a treasury director of SBRV. Welcome, sir. Over to you now.
Hello, everyone. Thank you so much to invite me, in special Dr. Senti, very good friend. And today we're going to talk a little bit about diabetic retinopathy screening in the AI era. This is my disclosures, nothing related to the topic of I'm going to talk. And this logo, I think everybody already know. This ChatGPT. And this one is also very popular. This is DeepSeek. And AI is in the life of most of the people in the globe. And everything starts with this guy, John McCarthy, in 1956 in the University of Dartmouth College, New Hampshire. He just organized a workshop, and he came up with this very good idea to put the artificial intelligence as a marketing name for this workshop. It's worked so much that until today, everybody's using artificial intelligence. And artificial intelligence is helping us in writing better, to research better, to make a lot of good emails, and also in medicine. In medicine, there's some image that we can work in the ChatGPT. And in medicine, many different fields are impacted by the artificial intelligence, but in special ones that has good image. Nowadays, we know that image is the key for using artificial intelligence in many fields. And in retina, we are special attention for AMD in diabetic retinopathy. And the AI can work with you to classificate the disease using for segmentation to measure fluid inside the retina, or predict if you have a possibility to improve vision or if you need treatment. And many things will come in the future with the improvement of artificial intelligence. And for have the deep learning or the neural deep learning, we need a lot of image. The image are studied by layers, and these layers can get very good result. And in the training for diabetic retinopathy screening, we have three very important steps. Initially, the learning phase. The second is the validation phase. And in the third is we can use to learn even more. And then nowadays we have 4 different algorithms that can give the diagnosis. The oldest one is the luminescence, has the old name EDR-XDR, the iArt, the AI, and the Retina AI Galaxy. All these are FDA approved, and they are currently used in US. And how did these things work? The patients go and have a fundus picture, a retinography, and after that, the algorithm gonna make the gradable, and this is gonna say, oh yes, you have some kind of retinopathy, and we have refer these patients to the eye doctor, or you don't have any retinopathy. And we can make these patients go for retina specialists and try to treat if necessary. And nowadays, we have very good cameras that has high quality photography from the back of the eye. And this high quality can really helps a lot the algorithms, the accuracy of the diagnosis. And the workflow is capture image, the image is going to be uploaded in the cloud, and this cloud has the capability to analyze the image by algorithms, and we have the result. This is going to take 30 seconds for 1 minute, and we can refer to the specialist for treatment. And now we're going to just tell some word about my experience. We are now running a validation study in Brazil for diabetes screening with AI. The background is we have a global pandemic problem with the diabetics, and diabetics is the leading cause of destroy vision in the work population. And one third of these patients has some kind of diabetic retinopathy, and many has not opportunity for screening every year. And we have late stage diagnosis. This late stage diagnosis in many undeveloped countries like Brazil, we have very poor outcomes. And here is a paper that shows Brazil has average of 16 million diabetic patients, and around 30% is undiagnosed. About 5 million people has very late diagnosis because they don't have opportunity to see an eye doctor. And even in US, around 50% of the diabetic patients has late diagnosis of retinopathy, and 40% are delay the treatment. That's very bad for the outcomes. And why we should think about using AI for screening? Because just screening is time consuming, and AI gonna be fast and very cost effective, and reach very under care populations like rural area or people that has very low income. And some researchers has shown AI can improve in 40% the productivity in the diabetic screening field. And now we are testing the Luminetics, the old EDXDR, that has around 87% sensitivity and more than 90% specificity. And the objective is to show that these algorithms can really work in Brazil population. We are doing this validation screening, and we are now screening up to 5,000 patients in 3 different locations in Brazil. We're gonna take 1 year, and we're gonna use 6 Topcon NW500 fundus camera. That's our capability to use the EDXDR, luminescence core algorithms. The method is to capture image instantaneously to be reading by the algorithms, and also these patients go for specialists and do a traditional screening with retina specialist. And they're gonna measure feasibility, accuracy, efficacy. And we are also organize a very good database of this patient that's gonna helps a lot to improve the AI. Artificial intelligence is a revolution that's gonna really change the course of diabetic retinopathy in the globe. And in conclusion, I can tell you that it's faster and enhanced care. We're gonna have early detections and better outcome of many patients. But nowadays, we have very underuse of AI in many different countries in undeveloped worlds. I'll just remind you that the EVRS meeting gonna be held in Cancun, Mexico from 12 to 15, and also the Retina World Congress, we're gonna be in Fort Lauderdale, May 14 to 17. Thank you so much for the kind attention.
Thank you, sir, for this wonderful presentation. Any questions from the panelists? Any questions? Thank you, all the speakers. Now we move on to the next panel.
Thank you.
A very good evening, everybody. We now move to session 3. Am I audible?
Oh, yes, I can hear you.
Yes, so the
I can hear you
session
too.
the session 3 is about flaps, bags, and IOLs, the other side of VR surgery. The first speaker that we have is Dr. Cristina Economou. She is half Italian and half Greek and earned her medical degree from the University of Messina in Italy in 2005 and completed her residency in ophthalmology. She joined the Ophthalmos Research and Educational Institute in Cyprus, Nicosia, and is a specialized VR surgeon. And she mentors young colleagues in the OR, supporting them to begin their careers. Over to you, Dr. Cristina, for your talk.
Thank you for the introduction. I would like to welcome you all and to thank the Ophthalmologica organizing committee for inviting me. It's a great opportunity and pleasure to share and connect with you. So today's session, as we said, is the other side of vitrectomy. I'm going to share now my screen, and I'm going to present a Carnevale scleral fixation IOL with a sutureless technique in a pediatric case. So we know that Carnevale scleral IOL doesn't require sutures to secure the haptics, but you still need to use some sutures to secure the scleral flaps and or the conjunctiva, because if you use the techniques with scleral pockets, probably you will not need to secure the pockets, but the conjunctiva, yes. With a Hoffman pocket trocar assist technique, I'm making 2 Hoffman pockets 180 degrees apart with the opening on the limbus. I will only use 3 sclerotomies with 25 gauge trocars in this case. The patient is a 4 years old little girl who came to examination with her 6 years old sister, and they were both affected by idiopathic lentisectopia, which is an autosomal dominant trait. And she was tested for Marfan's, of course, and homocystinuria, and she was negative. She had an initial vision of 6 out of 60, and amblyopia and exotropia. They were both operated on both eyes. I'm going fast forward to the video, and I'm marking 180 degrees
Your
apart.
slides
Yeah.
are not visible. Your slides are not visible, Dr. Cristina. You need to share your screen.
I'm so sorry for that. Yes, I'll try now. Βοηθάς λίγο να κάνω το screen, to share my screen. Just a second, I'm really sorry.
Sorry.
We must then. Is it visible now?
Yes, it is visible. Could you just run through the introduction quickly so that we have a decent idea about the patient?
Yes. Do you have a full view of the screen now? Yes.
Your slides are visible now.
Are visible. Okay. This is a Hoffman pocket trocar assisted technique, and opening from the limbus, 180 degrees apart, only 3 sclerotomies, 25G trocars, no sutures. This is the patient, 4 years old girl, 6 out of 60, the vision, amblyopia, exotropia, no Marfan or homocystinuria, but positive for idiopathic lentisectopia. Her sister also affected, and both were operated on both eyes. Okay? Can you hear me?
You are audible, yes.
Yeah, we can
Okay,
hear you. We
perfect.
can hear you. Can you share the you are showing the slides, not the presenter mode. So if you can put the
You can switch to the full screen mode.
yes,
Yeah.
yes, we can. It's right now. Yeah, it's okay now.
Yes?
Excellent.
Okay. I'm really sorry about this. So I'm going fast forward to the video, okay? So this is the marker, 180 degrees apart, marking the entrance of my sclerotomies, kind of. And I'm with a caliber now in the marker, marking 2.5 millimeters wide and long scleral pocket, okay?
So I'm using a 15-degree blade to make the first opening, and then I'm going to take my crescent knife to completely open my Hoffman pockets, and I will want to repeat the procedure on both sides, on the other side as well. Then I'm going to insert my infusion line and 2 trocars, 1.8 millimeters from the limbus. I'm going to use those 2 trocars to do my complete lensectomy, and I'm applying some scleral depression to better visualize the masses behind the iris. I want to do next anterior vitrectomy, and now, of course, I'm checking for any breaks 360 around the retina. Following that, I'm making my incision on the steepest axis. I want to make it wide enough so my injector slides freely through the tunnel without making any distortion, my side port. And I'm placing the lens on the cartridge. I want to push and place the leading T-plug on the opening of the cartridge, and I want to protect the following plug by pushing closer to the body of the lens, so I minimize the risk that it can get trapped by the piston. While I'm injecting, I'm switching off my infusion, and I'm rotating clockwise to better visualize the leading T-plug coming out of the injector. Once I intersect the plug with my forceps, I don't pull, I completely inject my lens, and then I pull and remove the trocar and pull, externalizing the plug out of the sclera and the conjunctiva. Then, with a handshake technique, I'm going to grasp the base of the plug, and I will serve it on the other hand with the forceps. I'm going to grasp and externalize with the same technique by first removing the trocar and after pulling out the plug of the sclera. After that, I'm going to use a second instrument to pull the base of the plug and drag it inside my pocket. I will do this on both sides, and my operation is actually finished. So this is how the Carnevale lens is made, has a specific curvature, and there is an indicator on the body of the lens, so you know that the lens is properly positioned. So I don't know if you actually notice that this lens was implanted firstly upside down, as the arrow indicates. So what to do? Do you leave the lens? You cannot leave the lens, because the curvature is made for being implanted in a certain way. So what I actually had to do, it was to disengage the plug and put it, once I flip the lens, put it back in proper position. This is the post-operative image, the first day. And at the follow-up, 4 weeks for one eye and 8 weeks for the other one, the visual outcome was 6 out of 12, and the refraction was +2 on both eyes. No complications, centered IOL, no captures of the lens, no transcleral plug exposure. And she's under care of the orthoptics department to take care of the amblyopia, and the strabismus operation has to be considered. So making a surgery means firstly plan the surgery. So I want to personally check my table and my instruments. I use a marker and a caliber, and I have extra trocars available. In these cases, it's crucial the target refraction, because in grown children, you can have this myopic shift, amblyopia, concomitant strabismus, so you have to take in consideration everything. And the postoperative refraction is, according to age, the following. So every 2 years, you actually reduce by 1 or so dioptry. I think that I went through the tips, through the video on the majority of the tips, but I want to emphasize that the size of the gauge cannot be smaller than 25. Don't use a 27. You're going to damage the trocar, the plug. In addition, I want to say that there are some curved forceps that are really helpful, especially if you have an ophthalmic eye. In this case, though, I use the Ultra Peel 25G straight forceps. Definitely not serrated because you're going to damage the plug. So you can have some unexpected issues like the one that you saw. And some of them can be that the pocket turns into a flap because you pull too much maybe. So this can be sutured. You can damage the plug, and if it's half of the T, then you can still implant it. Maybe you want to put a suture just to secure the plug, or you can anchor the base with 2-point sutures. If the plug is totally damaged by on the base, maybe you will want to use another lens. Pulling too much out of the sclerotomy, you have to push back the plug with forceps unless the IOL will be decentered. It can happen that the IOL goes directly to the vitreous because you didn't intersect the plug, so you have to use light pipe and forceps to extract it, to pull it up. Or you can have the IOL hanging in the vitreous from one side. So you already placed the first transscleral plug, and then accidentally the IOL goes back, and behind the iris you cannot see it. So you can use some scleral depression to put it back into your visual field, let's say. Or you can put a trocar and then insert a forceps or a light pipe to push the lens up. If you have an iris captured in the sclerotomy or the plug, you can consider to reposition the plug or the trocar, and to use some mycolin to retract the iris. Of course, as I said, implanting upside down is not an option, so you have to reposition. There are no many cases reported in the literature of pediatric Carnevale implantation. I actually found this retrospective study made by Stratos Gotzaridis and his collaborators, where they followed up for at least 6 months, 5 eyes only, in children with the same technique. And the conclusion was that there were no significant complication, and that this is a technique that is safe with excellent outcomes. Thank you for your attention.
Thank you, Dr. Christina, for this ingenious modification of the Carleville IOL implantation technique. Any question from the panelists?
Thanks, Christina. That's very interesting. Can you tell us what to do when you find it upside down, and what is your tip to prevent it from going upside down? Because I had the same problem before.
Yes, okay. What happened here, maybe the video doesn't show, I had to cut it out, of course, for restricted time. It was that it got trapped on the iris. So it didn't go half underneath the iris and half on the anterior chamber as I would like to. So in this case, I first thought, okay, I will secure the lens. So I pushed the plug out of the sclera to make sure that it's not going to fall in the vitreous or whatever. And then what I did is I actually took with my other hand, I took the body of the lens from the side. I disengaged by pushing with another forceps the plug, and flipped it with two forceps, half in the anterior chamber and half in the posterior. And because the pupil was not so dilated, it could keep the IOL by falling behind, by falling in the vitreous. So preventing is to have a good dilation, and I think that you should inject a little bit towards the posterior chamber, not on the anterior. So if you have implanted the lens properly in the injector, it's going to come out properly in the normal position. This I would say. And something else I said, but maybe is not pointed out enough, that when you inject, you don't want to have the infusion line open, or at least you have to lower the infusion pressure, because you have loss of vitreous as first, and the pushing of the lens outwards. You don't want that. You want the lens to go smoothly inside towards the posterior chamber. Did I answer your question?
Yes, thank you.
Okay.
Thank you.
I had one query, and Dr. Christina, is this your conventional way of implanting the Carleville IOL of tucking the haptics underneath the pockets? And if yes, have you ever encountered broken haptics while doing this manipulation?
Yes, I must be honest, it happened, but usually when I would say that the most common problem here is when you pull the base to drag the plug inside the pocket, that you can actually pull also a little bit of the haptic out of the sclerotomy. And this, you end up with a decentered lens. So you have to be very careful the way you pull. It needs, you have to do it once or twice to actually finesse the technique. But usually I think that the broken, the damage of the plug is because you pulled too much and with a lot of force, you pressed too much, not because you pulled it out. And what I usually do to prevent also this is that I grasp the plug not from the very end of the T, but from the middle. Do you understand? Where the base is, I grasp it from there, so it smoothly comes out.
I get it. Thank you. Thank you. I guess it's time to move to the next topic.
Can I ask one quick question to Christiana?
Yes.
That was an excellent surgical demonstration. I wanted to know how far were those trocars made, because they were interesting that you pulled out through the trocars and then you had to remove the trocars, right? When the haptics come out.
So how long you mean the
How far
trocars
from
are?
the limbus?
1.8, maximum 2. Initially, I was going closer to 1.5, but I had some a case of iris captured, so I moved a little bit towards the 2. So I want to move between 1.8 and 2 millimeters from the limbus. And of course, when I place the trocars, I respect the direction that I want to keep for my forceps. So it's not perpendicular, but
so when you're pulling the haptics out, you have to remove the trocar and then pull your.
Yes, I just remove a little bit the trocar, so I see better the tip coming out, because the forceps, if you notice, they have a point where you can see the actual opening of the forceps.
Okay.
So when I see when the forceps is close to the opening, I know that I'm close enough. And what I usually do, I use both hands. So with both hands, very slowly, I remove. You don't want to do any sudden movements. You will damage the back. So you just pull it back a little bit.
That was interesting. Thank you.
Thank you.
Can I to make the scleral
Christina,
flaps.
can I ask a question? Christina, excellent talk.
Yes.
I have a question about the sizing of the lens. So the Carleville lens is designed for adult patients. And do you have to do something special when you're operating a 4-year-old child in terms of the distance from the limbus?
No. It's the same lens. The only issue that you can have, it didn't happen so far, but I have operated 4 kids. Not much literature anyway on these cases, but Carnevale lens goes up to 30. So if you need to use a 31, 32 is not available.
No, I'm talking about the sizing in terms of the length of the
lens. No, the sizing is okay.
Eyeball size. Yeah.
No, the size is okay. The size is okay because it's a flexible lens. So it actually follows the growing eye. The only problem that I have with Carnevale is that it goes up to 30. So it's actually the force of the lens, the power of the lens, but not the size.
Yeah, so in a 4-year-old child, probably the lens will sag a little down
Yes,
posteriorly, but as the eyeball grows, then it tends to get more flatter, isn't it?
yes. But
Okay.
this follows a little bit also the myopic shift that is going to happen on the growing eye. So
Yes.
you need to prevent that. And that's why I emphasize that is crucial to know what is your targeted vision and to understand whether to place your, let's say, your target. And of course, we are talking about children that have like 6 out of 60. They have amblyopia, they have
Amblyopia.
strabismus. So of course, half up, half down, I don't think is a major thing.
Major difference. Thank you so much.
Yes.
Thank you. Thanks.
Thank you for your questions.
Thank you, Christina. I think we'll move on to the next speaker. We have Dr. Abdullah Elaban with us. So he's an experienced consultant ophthalmologist in vitreoretinal surgery and complicated cataract surgeries. He resides in based in Hull and East Riding of Yorkshire. So I think over to you, sir, for your talk on iridodialysis repair in traumatic cataracts and severe zonular dialysis.
Hello, hi, good afternoon, everyone, and thank you very much for your introduction. Can I just confirm, can you see my screen?
Yes, all good.
Excellent, excellent. So this is a case which was referred to our vitreoretinal surface, and this is a chap who had a 40 years ago trauma to the eye. There are three main problems here: the traumatic cataract and the large inferior dialysis, in addition to the zonular weakness. I sped up the video to 4 times. There is here large area of iridodialysis, about 4 hours, but just expect the zonular damage is usually more than that. It's about 5 to 6 hours. So we planned the surgery by putting a couple of iris hooks to dilate the pupil, and then we'll paint the anterior capsule to do the capsulorhexis. The main tip here is to try to make a capsulorhexis about 5 millimeter and centered on the lens, not the pupil. So we'll slowly progress with the capsulorhexis. It's really important to be a good size and well centered around the lens to avoid further problems later on. And then I'll extend it a little bit here under the area of the pupil to achieve a decent size, about 5 millimeter. Following that, we plan to do some capsular support. So I placed a capsular retractor here. The main tip here is to make a small pocket under the capsulorhexis for insertion of the capsular retractor. And once you put it in place, really important to push it a little bit so it can be hold tight within the capsular back complex. And now the back complex is well supported, but still there is a large area of zonular weakness. So I placed another capsular retractor to make sure the bag is well supported. And then this is a little bit hard lens, so we'll do like a horizontal chopping. In these cases, I do what I call hybrid chopping, where I do a little bit of a groove and then move to horizontal chopping. And it was a hard lens following the trauma, so a bit by bit it's coming. Really important here to minimize any zonular stress, which can cause further zonular damage. So I'm trying to work a little bit on the pupillary plane and slightly anterior to the capsular back. Once we remove the lens, make sure any remaining fragment, and then a little bit of viscoelastic injection to avoid any collapse. Proceeded as usual with the IA. Slowly it's coming. Really important in this case, we expect an area that the vitreous can prolapse at any time. So whenever I come out, I inject viscoelastic like the classical teaching. And once I come off, now we have removed the cataract, we cleared all the lens fibers. Next step is to put a CTR. This is a guided technique for CTR insertion to minimize any further zonular damage. Once I put it in place, I start to release it, and we can see the area of through the area of zonular dialysis that the CTR is well centered in place. Now the capsule is well supported, so we'll remove the retractors and move to the next step. I found that in this case, CTR is not enough and will need an extra device. So I planned a bucket for the capsular segment. So once I dissected it, I measure about 2 millimeters from the blue line and make a small groove for the insertion of the capsular tension segment. There are different ways of putting it. I prefer to put it into as anterior chamber, and I plan to suture it with a Gore-Tex suture. Uh, Unfortunately, the Gore-Tex suture comes with a caved needle, so you need to straighten it to be able to pass it through the whole of the segment. Once you pass it from one side, you repeat the same. You insert the needle and dock the Gore-Tex needle. And once the Gore-Tex needle is docked, you put the capsular segment. At this stage, I'll try to tie the knot, but will not secure it, as later on I may need to tighten it. And you can notice here, once we put it in place, the capsular axis is very well centered over the visual axis. So we'll now remove the hooks and move to putting the lens implant. I decided to put lens implant slightly away from the segment, so which means that we get an overall good support to the capsular back complex, and then injected Myocol to decrease the size of the pupil. And then we'll move to the next step of repairing the iridodialysis. I made another groove about 1.5 millimeter, and the main idea of the groove is to be able to bury the suture later on. And then I'll plan like a mattress suture with a 10-0 Berlin. So I'll put a central one initially to see how many sutures I will need later on. One important tip here is to try to make the suture slightly away on the scleral side compared to the iris side, because you will help to stretch it at the end. And this is a 10-0 Berlin. It's a little bit fiddly, but a bit by bit it's coming. And once we made the first mattress suture, we'll slightly pull on it. Again, we'll not tighten it too much here, just make sure just to approximate the iris. Then we put another one just on the side of it, applying the same principle, a mattress suture slightly fanned out from the scleral side compared to the iris side. The 10-0 is very fragile, so it needs a little bit extra caution while we are putting it. And this is the second suture. After cutting it, I realized that I will need another suture. There is still some iris defect over there. So we'll repair it in the same manner, slightly extend that groove to allow for the third mattress suture. You can use a micro forceps just to help with pushing the iris. The main idea here is to try to grasp a little of the iris tissue, little enough to hold the suture and not to cheese wire. So in this way, you put like 3 mattress sutures to secure the iris in place. Once we put the 3 sutures, we bury them in the groove, and this is the main advantage of the groove. Similarly, we'll tighten the Gore-Tex suture, cut it. Also really important to bury it because it can easily erode later on. And once we made sure all the sutures are buried within the groove, we then go to clear all the viscoelastic. And once the viscoelastic cleared, I just did a little bit of a stretch. The main idea here is to prevent the iris from curling at the angle and to try to stretch it a little bit. And then the final step was to put just 8-0 Vicryl to close the conjunctiva and then hydrate the wounds, and the surgery was concluded. So this is how it looked at the beginning, and this is at the end. So we put a capsular tension segment, and we put 3 iris sutures, and then we also put the CTR here to enforce the capsular bag complex. And this is how it looked after 4 weeks after the surgery. The lens implant is well centered, pupil size is very decent, and the patient has good visual outcome. And that's it. Thank you.
So thank you, doctor. I think You made a very challenging case look very simple, but I think all your take-home points were bang on. The way you used the iris hooks first and then supporting the capsular hooks. And I like that interesting point where you said you'll have to center the rexis according to the size of the lens and not the pupil, because sometimes in these hydrodialysis, you tend to go towards the area where there's dialysis and then go closer to the zonules and it can cause a runaway. So I think
Yeah.
it was excellent surgery and it was a very hard cataract also in this particular traumatic case, isn't it? So well managed.
Yeah.
If anybody else has any questions or points.
Yeah,
Just
thank you. Just one
compliments,
comment.
nothing else.
That's
Excellent
uh,
presentation.
Thank you very much. Yeah, just to highlight, it's not as easy. It took like 50 minutes, this surgery, but just for the audience, especially young doctors, we just editing it for the 7 minutes, but it took 50 minutes or so. So it's a long surgery. And also, I planned it. The main message here for the young doctors observing us is just to plan. So we addressed three main problems. Make it step by step, because you don't like doing a step, oh, I should have done that earlier, and then move back it again. So a bit of planning, make sure the equipments are ready enough, and be ready for the surprises during the surgery.
That's right. My just one small question is like, but is it absolutely necessary in this particular case for the segment, or just like for an additional support? Because it didn't look as if they had too much of phacodermosis when you were doing the phaco.
Oh, that's a very good point. So initially, on slit lamp, there is about 3 hours of iridodialysis. But most of these cases expect the force to damage the iris more likely to have damaged more zonules than the iris. So the zonular weakness was about 5 to 6 hours. When I started, I was planning only to put one capsular retractor. But later on, I realized no, I need more, because there was a little bit around 4 and 5 o'clock more zonular weakness. And we went to the surgery, we put a CTR, but after putting the CTR, it's not well supported. So then I was preparing a standby capsular tension segment. So in that scenario, I feel it's needed. Let's say if the zonular weakness about 3 hours or so, it can go well with a CTR only. If it's 4 or 5 or more, most likely you'll need a segment.
Sure. I think that's again good take home points. And I liked in the end of the surgery when you pull the iris, because that is something we never thought of. Because as you said, when we tend to pull, it gets stuck to the root. So that was
Yeah.
nice, but you have to be really gentle.
Yeah, that's a good point. Yeah, although this step actually it's a bit traumatic, holding the iris, grasping it, it's a trauma. But on the other side, if you put 3 sutures, you don't want the iris to curl at the angle. I actually did a gonioscopy for that patient, and we try to minimize it. So minimize it by, when you pass the suture through the iris, try to be as peripheral as you can. Just grab a half millimeter of the iris or less. Not more and not less, because if less than that, it will easily cheese wire later on.
Okay.
Abdullah, I have a question from you from Egypt.
Oh,
This
thank
is
you.
Ihab saying hi.
Hi. Hi.
Good to see you. Uh, I'm always thinking about the relative weight of things in relation to others. Do we ever know? This is a kind of a philosophical question. The weight of the IOL, the weight of the Sione ring, the weight of the capsule tension ring in relation to the damaged bag. Would this be heavier or heavy enough to maybe pull it or exert some additional dialysis? You did a wonderful phaco and with a quick chop, and it was great. And I'm sure that with as a good surgeon as you are, there were some more damages to the zonules here and there on the dialysis site as well. So would this be able to hold all this weight on a long-term perspective? This is the question I'm always wondering about.
No, that's a very good question, and thank you very much. Nice to see you after a long time. Yeah, it's really important. Generally speaking, if you want to do a surgery, try to be minimalistic. Do the minimum possible. This surgery we did in a VR setting because there was a possibility that the capsular bag is dead. We end up to remove it completely and do a scleral fixation. And actually, we prepared the scleral fixation lens. But there was some, initially, we tried to put it. And you may have noticed when I put the IOL, I tried to keep the IOL away from the area of capsular segment. If I didn't put a segment, I will plan the IOL on that direction because sometimes the haptic of the IOL can push and give you some zonular support. But you never know. Ideally, we put Gore-Tex sutures because it's most likely long-lasting. But the tricky part here is that the Berlin sutures, which we are expecting to break up after 10 years or so. So these Berlin sutures most likely will break up later on in life. Like if you remember the old days when you used to secure the scleral fixated lens with Berlin.
Yeah, but look, I think by the time some adhesions would have happened and the sulcus and the
Yes.
iris would remain there as well.
Yeah, that's our hope in the future.
Great.
Yeah,
Great
thank you.
case. Thank you.
Thank you.
Thank you, Eleven, once again. That was a wonderful surgical demonstration.
Thank you very much.
I think we'll move on to the next speaker.
Yeah. So, hi everyone. So, I would like to now invite Dr. Prasanna Rao to deliver his talk on scleral fixation using aqueous IOL with Gore-Tex suture. Dr. Prasanna Rao is a distinguished vitreoretinal surgeon who has been practicing VR since almost 3 decades, and he heads the ophthalmology unit at Medcare Eye Center in Dubai. Over to you, Dr. Rao.
Thank you, everyone, and thanks, Vaibhav, for this invitation. Am I audible? And is my screen seen?
Yes, sir.
Yeah.
Okay. So I'll just give a little brief about Gore-Tex sutures. It was mentioned in the last presentation. So Gore-Tex suture is widely used in cardiovascular surgeries for over 20 years. And the reason being it has a very low suture breakdown over a period of time. It's strong, easy to manipulate, resilient, and more importantly, it's non-inflammatory. The problem with the suture is if it's sometimes thick, when you end up making a knot, it's difficult to bury the knot through your sclerotomy. And note that this is an off-label use for intraocular use. Aqueous lens, all of us know it's been there for quite some time. The most important feature of it is it's got a zero spherical abrasion. So because of that, it gives some enhanced depth of field for the patients and has enhanced contrast sensitivity and the stability with descentation. Because of the uniform center to edge power, this is important because when you plan scleral fixated lenses, you want to do it. And it's got a 360-degree square edge, hydrophilic acrylic material. So there's low risk of dysphotopsia and glistening in these patients. Bear in mind, some of these patients can develop opacification if you use intraocular air or gas. However, the rates nowadays mentioned are very low in these patients. This is how the aqueous lens is placed. So you have the Gore-Tex suture passing through the two arms haptics. And again, there's a marker on one of the haptic which indicates the appropriate direction where the aqueous lens needs to be placed. I just labeled this diagram a little bit for us to understand. So this is the lower left suture. This is the upper left suture, lower right and the upper right. The reason I've numbered them is because this is the way I put the sutures when I'm exteriorizing the sutures to the sclerotomy. So I have 4 videos. I'll try and be a little quick. This is a 12-year-old boy with Marfan syndrome. The mother had Marfan's and she lost her vision because of retinal detachment. And this is the way the patient presented with. So he's got a subluxated lens here. So we mark the two corresponding points. Then a standard lensectomy is being performed with a 25-gauge instrument. And once the lensectomy is complete, as described by Christina, we do a scleral depression to remove the peripheral edge. I prefer to do a complete vitrectomy in patients because I want to make sure that the vitreous doesn't get involved later in life, especially in patients with Marfan's where they have a high incidence of a retinal detachment. I also do endolaser in the periphery after examining the peripheral part of the retina. And once this is done, the next step is to plan putting the intraocular lens. So the measurements are done. It's usually 3 millimeters from the limbus on either side. A scleral groove is made. Then you feed the haptics around the aqueous lens, and two other sclerotomies are made. This is the way the sutures are introduced. The lower left first, then the upper left is passed on out through the sclerotomies. This was one of my first cases. So the tip here is don't hold the tip of the suture. Use it a little away, which helps you to remove the suture outside. Then the lower right one is exteriorized. So at this point of time, you have three sutures which are actually coming out of the sclerotomies. And this is using a handshake technique. And the sclerotomy is brought out. The suture is brought out through the sclerotomy. And then the aqueous lens is folded and implanted in the eye. Note that the fourth suture is not being placed here. Once it is injected inside the eye, you pull the lens slightly towards the left. This allows you to see the haptic here as well. And then using a maxi grip forceps, the fourth suture is exteriorized. This ensures the least amount of entanglement of the sutures, because you see there are four ends of the sutures, and then the sutures are brought out and tied. Initially, as mentioned, you just tie it very loosely just to make sure that the lens is centered. So here you can see it's being pushed to the right a little more. Then you tighten the left suture and you bring it in the center. The main suture is closed off, and then you complete the Gotex suture knots 311. And once that is done, you actually bury the knot into the sclerotomy. Once you bury it, you can actually trim the knot and make sure that the edges of the suture is also buried inside. You can use your max grip forceps. I left a little air bubble in the eye in this patient. I know there's a risk that these can get opacified, but this is how the patient was post-op. So pre-op, you can see how the lens looked like. And this is 4 years post-op. Pre-op vision of 4.2 with severe astigmatism. Post-op is really doing well, 0.9 vision. And that's 4 years later where you can see the edge of the aqueous Gotex suture. It's very hardly causing any inflammation in the eye. The patient is doing well. We did the other eye as well for this patient. The next patient is a patient who came with a dislocated lens about 12 years after the surgery. So similar technique, you open the conjunctiva on either side to allow placement of the Gotex sutures. And then you do a standard vitrectomy. I'll just skip this portion. I'm sure everyone knows this. The IOL is finally lifted on, a good peripheral shave being done, ensuring that the sutures don't get entangled. The opening in the, an opening in the cornea is made, and then the lens is lifted and is brought out of the eye and removed. And then exactly the same technique. The sutures are passed through the aqueous lens, and I've kept it a low magnification to allow you to see how the sutures are done. So you go from above down on one side, and from the other end it's below up. So once you pass your 4 sutures, then you exteriorize, as I said, the lower left first. No need of holding it to the tip. Keep some gap there, and that allows you to hold this Gotex suture outside, and then you exteriorize it. Once you exteriorize the Gotex, then the second one is done. You need to just ensure that there's no, the knots, the suture doesn't get knotted in this edge. And then using a handshake technique, the lower right suture is again brought out. You pass it into the anterior chamber. The second instrument holds it, and the lower right one is exteriorized. Then the lens is placed in the eye in the standard manner. Important to push it into the vitreous cavity, anterior vitreous cavity. And once that is done, you want to pull the sutures a little towards the left so that the lens is getting pulled towards the left, and that allows us to see the haptic here. In fact, you can see a little iris prolapse, which sometimes, I know it's not good, but it helps you to see the haptic here very clearly, and also helps you to exteriorize the knot. So once this is exteriorized, you follow the same protocol. You just remove the trocars, and once that is done, you want to tighten the sutures and then center the lens after the Gotex have been tightened. So this is at the end where you have to just bury the knots as well. And finally, the infusion cannula is removed. This is a patient with a microcornea, 27-year-old lady. She was operated at the age of 5 years with for a surgery. So she's got aphakia, microcornea, and nystagmus. So you'll see me doing pretty much the same thing in all the cases, doing a complete vitrectomy for her as well. And after the vitrectomy, pretty much the same steps. The sutures are passed the same manner. And I like to follow this lower left first, lower right, lower left, upper left, then the lower right, and finally, after inserting the lens, the upper right one. So this ensures that you don't get the sutures entangled, and there is very little risk here of the lens tilting in these cases. Okay, and I'll go to my last case. It's pretty much the same. So this was an interesting case, a 37-year-old lady who underwent scleral buckle, also had an RK done with a subluxated dense cataract with a detachment. So I did a past vitrectomy for her, removed the cataract and put oil for her. And this is post when she came for a follow-up. So in her case, the thing was a little tricky because she had a lot of these RK cuts. It was a little difficult to make a clear corneal incision. So in this case, we decided to do a scleral tunnel for her. So after the oil was removed, this is the oil removal. A scleral tunnel was made in the superior quadrant. And once the scleral tunnel was done, you use the scleral tunnel to implant the lens in this case. Yeah, so I'll just quickly go. It's pretty much the same here. You do a handshake technique to implant to exteriorize the Gore-Tex from the lower right corner. And that's how the sutures are tied, and make sure the knots are buried inside and the conjunctiva is closed. I'll show you the follow-up picture of this patient. So this is how she looks after surgery. There's a very well centered lens. That's the Gore-Tex sutures, which pretty much looks inert every time. And this is the optos fundus photograph. So thank you very much for your kind attention.
Thank you very much, Dr. Rao, for those wonderful videos and nicely illustrating the techniques of the aqueous IOL. So I would just open the discussion to the panelists. Are there any questions?
I would like to make a question. What size of trocars are you using?
So actually, it depends on the suture which is available. So ideally, you're supposed to use a CV8 suture, and I use a 25 gauge. But often, if CV8 is not available, I would use a CV6 suture, which is slightly thicker, and then I would use a 23 gauge needle system. Now, the problem with the 23 gauge system is the suture sometimes, when you exteriorize it, the sclerotomy ports are slightly open. So you can actually suture the sclerotomy, making sure you don't cut through the Gore-Tex suture. So if due to non-availability, if you have to use a wider gauge, like a 23 gauge, you can still use a CV8, and that works very well.
Thank you.
So I had a question. So Dr. Rao, you showed the aqueous IOL used in different varieties of cases. So what are your primary indications for using this IOL?
So
or do you use any other IOLs also as a second?
So I started with glued lenses, 3-piece glued lenses. Then I started using 3-piece lenses without just doing a flap, which has been described from India as well. No glue, no cauterization, nothing. I don't do Yamane because I'm not convinced. It requires a lot of learning curve. And eventually I landed up doing aqueous with Gore-Tex. Now I'm slowly shifting from aqueous to using the 60 Prolene, like a 4-flanged technique with the 60 Prolene. I think that seems to be a little more technically easy, but having done a lot of cases with aqueous, I think it's a pretty good lens. The only issue is if the patient lands up with a detachment or the patient requires some corneal procedure where you need to leave a gas bubble in the eye, I would be slightly concerned. But having said that, these lenses are very stable. They're pretty good in terms of long-term stability, and the results with Gore-Tex are very good. But the reason I want to shift is because ideally, when you're doing any procedure, you need to know learn all the various ways of doing it, and then you stick to one technique which is more comfortable for you to do. So if I shift, currently my go-to method is Acryos with Gore-Tex, but I'm trying to trend more towards doing Gore-Tex with a 6O Prolene.
Okay, but have you come across?
Excuse me, sir. What about? Sorry.
So yeah, Christina, please go ahead.
So, what about Carnevale? Is it available?
No, it's not available. Unfortunately, not
why.
available. That's
Yeah.
the reason we have to look at other options. Yeah.
Yes.
Otherwise, that's an excellent lens. I think the only concern is the haptic breaking through. So even when you hear Professor Carlevale talk, he always has a point that you always need to have a standby lens. And then it becomes difficult because you have to order 2 lenses of the same power. And sometimes the companies won't take back the second lens if you're not used it. Yeah.
That's true, but even if you damage a little bit the lens, you can still use it. Of course, if it's cut the whole haptic, it is not safe to use because you can have like a tilt of the lens, not very stable. But if it's not a huge damage, you can still fix it. And the learning curve is
very easy.
is short. Is short.
Very short. Yeah, true.
Yes.
True. Very true. Yeah.
So I think if there are no further questions, we can move on to the next talk. I think because we are overshooting by 5 minutes. Yeah. Okay.
Yeah, I think Dr. Safran is not here. Is he on?
Yes, Dr. Safran is actually busy in the OR, and he has provided us with his pre-recorded talk. I'll be sharing my screen, and I'll just play his pre-recorded talk. Just give me a moment.
So in the meanwhile, Doctor, I have just one question I had. So have you come across any complications suture related with the Gore-Tex?
So suture related, no, but sometimes I would face a problem where the suture would get entangled and the lens would go inverted. So after looking at all the videos, I realized that this format of doing the order is lower left, upper left, lower right, and lastly the upper right. That seems to work very well.
Okay.
The suture entanglement is also very less. Leaving the suture subconjunctivally, I don't think has had many issues because it's a very smooth suture. It's like when you do a buckle, when you place the suture over a buckle, and the suture just stays in the subconjunctival space sometimes and doesn't get really eroded.
Sure. Okay. Thank you, Dr. Rao.
Shall I play the video?
Thanks.
Yeah,
Yeah.
Dr. Shitish, let me introduce first our next presenter so we can play the Dr. Shitish.
Yeah, please go ahead.
Yeah. So our next presenter is Dr. Steven Safran. He's from New Jersey, United States, and he has done his fellowship in cornea and external diseases from the Duke University of School of Medicine. His area of interest include anterior segment surgery, including cornea transplants, premium IOLs, and complicated cases. So he sent his pre-recorded presentation. So Dr. Shitish, kindly play it.
Sure.
I'd like to talk about dead bags, zombie bags, and the unusual suspect. I have no financial disclosure. Well, we all know now to beware of the dead bag. This is a thin diaphanous bag devoid of lens epithelial cells. There's no fibrosis at all, no capsular contraction. The zonules are disinserted, and this is prone to dislocation. You don't want to try to lasso these bags. The whole thing will shred and fall apart if you do that. You really need to remove these and replace them with scleral fixated lenses. So this is a psychiatrist that had cataract surgery 15 years ago. He has a very classic dead bag dislocation. You can see the capsular bag is reduced to nothing more than a diaphanous wisp. The whole lens bag complex was removed and replaced with Yamane intrascleral haptic fixation, and these patients can do very well. Single-piece acrylic lens within a dead bag can cause an UGG syndrome by iris chafing through the sheer anterior capsule. This is 78-year-old referred 10 years after cataract surgery. There's an Acrosoft lens in the capsular bag, but the patient wakes up every morning with blurred vision due to a microhyphema, which clears as the day goes on. Patients develop glaucoma from this bleeding and pressure's 32 on COSOP. And you can see here that when the patient comes in, I can't really see very much because of the blood, but I let the patient wait around a bit, things clear a bit. Then I could see that there is a thin, diaphanous, shimmering capsular bag, iridodenesis. The lens is completely within the capsular bag and covered by the anterior capsule. However, I could see iris transillumination defects on both sides over where the haptics are, letting me know that there's an UGG syndrome here. So I went in with a plan to remove and replace this single-piece acrylic lens with a 3-piece silicone lens. I supported the capsular bag, which was very flimsy with iris retractors, and it was very easy to remove this lens because there was no fibrosis. When I went to insert my CTR, I could see that the capsular bag just seemed to be kind of collapsing with insertion. So I took it out, inserted it manually, and again, the capsular bag just seems to have no support for the CTR. It's very thin and diaphanous, and this was before we recognized the entity of dead bags, or at least I knew what they were. Here I did a 3-piece silicone lens, glued IOL, and this patient did very well. Day 1 post-op, she looked very good, and she's now 10 years out with no further hyphema incidents and off all glaucoma meds. This is another patient, a physician with recurrent vitreous hemorrhages, was treated by pars plana vitrectomy from the retina surgeons multiple times to remove the blood, but still had recurrent bleeding and glaucoma. And he was referred to me after the physician healed himself by dislocating his lens bag complex onto the retina. And after that, he didn't have any more bleeding, but he couldn't see well. But here you can see the evidence of what was happening previously, the transillumination defects over where the haptics were sitting when the bag was in place, and their transillumination defects visible over the optic as well. So here's the lens bag complex sitting on the retina, and when I bring this up, you can see that the capsular bag is really just a wisp now attached to the IOL that used to be its inserted within it. And when I cut the lens and take it out, you can see this capsular bag studded with pigment that has no fibrosis, no integrity attached to the haptic. And this was replaced with the among-intrascleral haptic fixation, and this patient did well. There's a complex interaction between basement membrane, lens capsule, and lens epithelial cells where they sustain each other. In a dead bag, the lens epithelial cells, which are left behind, wither on the vine, they die off, and the capsular bag slowly loses its integrity. The zonules have nothing of substance to insert into, and then the bag just dislocates over time because there's nothing supporting it. And it's a bit like soil that you plant seeds in, but nothing grows. There are no trees to sustain it, so then the soil erodes. So the question is, does removing LECs during cataract surgery predispose to dead bags? And I don't think that this is the case. When you remove LECs from the anterior capsule, you're only removing those. You're not removing the equatorial LECs. And those equatorial LECs normally will proliferate and cause posterior capsular opacity. And that's the rationale for the sharp-edged IOLs that sequester the posterior capsule and reduce PCO. Removing LECs from the anterior capsule has no effect on PCO rate. Many studies show that it just reduces anterior capsule contraction of phimosis. And in dead bags, the LECs left behind actually are there, but then they wither away, and then the bag loses its structural integrity. Now, if you could remove all lens epithelial cells, it might lead to loss of capsule integrity over time, but you can't. And that's why I don't think sweeping the anterior capsule has anything to do with this phenomenon. So what's a zombie bag? Well, it's a bag that's only partially dead. The bag is still standing. The posterior capsule sequestered by a sharp-edged IOL is devoid of lens epithelial cells, and over time it loses its functional integrity, but the anterior capsule and zonules are still intact. There's variable capsular bag fibrosis and submarine ring material present. So here's an example of this. This is a single piece acrylic lens I'm removing after about a dozen years living in the bag. And when I gently visco dissect the capsular bag open, you can see the posterior capsule just gives way. It has no structural integrity. And again, this is most common when the posterior capsule has been sequestered by the lens for years and is crystal clear. Here's another example. It's a single piece of acrylic I'm taking out after many years. And you can see that this posterior capsule just shreds right here, adjacent to the haptic inferiorly. And this is because the capsular bag posterior capsule has lost all of its structural integrity, even though the rest of the bag has decent support. So here I'm going to go ahead and remove the posterior capsule and do optic capture. Single piece acrylic haptics can also erode through the posterior capsule and cause UGG syndrome via uveal irritation. Here's a 68-year-old referred from upstate New York. He had cataract surgery with a Restore lens done 13 years earlier, a repeat vitreous hemorrhage from UGG syndrome causing vision loss. The Thor's plane of vitrectomy was done, but the blood recurred. A Restore is in the capsular bag and a zero-power silicone IOL placed in the sulcus, but bleeding recurs despite that every few months. The other eye has no issues with the Restore in the bag. So I decided to watch him for a few months, but he returns with count fingers vision and vitreous hemorrhage, so really something had to be done. Question is what? So I brought this patient to the operating room, placed pars plana trocars and iris retractors so I could see what I was doing because the patient didn't dilate well. I took out the sulcus IOL, and then I'm going to go ahead and try to remove the IOL from within the capsular bag. And on this side, the lens, you can see the haptic is pretty well fibrosed in place, so I'm going to cut that. But the other haptic was just dangling loose because it had eroded through the posterior capsule and was irritating the ciliary body. So I took this lens out and removed the haptic that I cut. And now I'm placing iris retractors to retract the anterior capsule so I can inject a 3-piece acrylic lens and have it unfold in the optic capture configuration. So now this is optic captured. I'm cleaning the anterior capsule a bit, making that a little bit bigger, completing the pars plana vitrectomy to remove blood. And now this patient has an optic captured 3-piece lens. And day one post-op, you can see it's very secure in the optic capture configuration. And this patient is now over 2 years post-op with no recurrence or bleeding. Haptics can also erode through the dead posterior capsule, and the lens can then dislocate through that opening into the vitreous. Here's an example of a patient with the classic dead bag. The IOL has dislocated through the posterior capsule and the vitreous. And you can see where there have been previous chafing through the bag, transcapsular chafing of the iris. Here's the other eye where the lens is actually still in the bag, but in danger of dislocating because there's a similar rupture of the posterior capsule caused by the diaphanous posterior capsule being incompetent. Here's another example, a patient referred with a dead bag dislocation through the posterior capsule. The lens has eroded through the posterior capsule, dislocated into the vitreous. And here, during my pars plana vitrectomy, I'm able to remove this, take it out, so I can do Yamani ISHF. Now, for all scleral fixated lenses, please make at least one pre-eye to prevent reverse pupillary block. Reverse pupillary block can occur in vitrectomized eye with sulcus IOLs, and this can cause UGG syndrome. It's due to a one-way ball valve effect of the iris in contact with the lens. You can get dramatic posterior iris bowing against the lens, leading to hyphema. This can cause recurrent optic capture by the iris, and it usually resolves immediately with a laser iridotomy. This is what it looks like on gonioscopy. You can see the concavity of the iris. This is an example of what it looks like on OCT. There's a 3-piece IOL in the sulcus. You can see the iris in contact with the lens and the concave iris shape. And with the PI, this flattens out, resolves the reverse pupillary block. So what's the mechanism of this? When you create the laser PI, the opening for reverse pupillary block, you see the opposite what you see with pupillary block. Instead of a gush of fluid into the anterior chamber, you see the pigment fluid sucked out of the anterior chamber. This indicates that the IOP is actually higher in the anterior chamber than the posterior chamber, a compartment syndrome. The iris stretch and chafing causes an UGG syndrome with blood pigment blocking TM and elevated pressure, and this is a vicious cycle that's either relieved with optic capture of the IOL or by the peripheral iridotomy. So the question is, how can the IOP be higher in the anterior chamber than the posterior chamber? And there's only one way that this can happen. Aqueous flow has to reverse direction. And this is something we've been able to directly observe with this fillet lamp by examining the flow of pigment particles in the anterior chamber. This is a patient over 1 week post-op from Yamani intrascleral haptic fixation, and you can see the pigment particles moving from the anterior chamber to the posterior chamber, reverse of the normal aqueous flow. And here's another example of a myopic patient status post Yamani intrascleral haptic fixation. You can see the pigment particles flowing from the anterior to the posterior chamber in a reversal of the classic aqueous flow pattern. And there's a patient with the classic finding of pigment dusting of the Yamani fixated lens. When we dust the pigment off with the YAG laser, we can see that it's actually flowing from anterior to posterior chamber across the surface of the lens. Well, thank you very much for your attention.
So it's actually a very thoughtful presentation. Dr. Stephen is not present to discuss the case. So any comments by the other presenters or panelists?
Yeah, that's a very interesting presentation, and I really like the emphasis on the dead bag concept. It's really thoughtful for everyone to think about it. And I think the idea Dr. Safran highlighted about the importance of BI, it has been some controversies about it. Some people do routine BI for all scleral fixated lenses. Some do selectively. I think Christina or Dr. Rao, you don't do BI regularly for all scleral fixated lenses.
No,
I
no,
don't.
I don't as well. I have a question. For scleral fixated lenses, do you just do anti-vitrectomy or a complete vitrectomy?
Well, it depends. Usually I want to do the minimal, the minimum possible. So I would do an anterior vitrectomy if a posterior vitrectomy is not needed. But in your case, for example, with the Marfan, it was thoughtful to do it and to apply the laser because you want to secure the eventuality of recurrency of a retinal detachment or a new retinal detachment. But no, and especially for kids, I avoid to do the vitrectomy, to be honest. Yes.
Okay, thank you.
Thank you.
Thank you.
So thank you. We can move to the next session.
Thanks, everyone.
Thank you, everyone.
Thank you. It was a real pleasure.
Thank you.
Thank you, everyone. Thanks a lot. Thank you.
Thank you.
Can we start the next session? Can we start the ocular oncology session?
Yes, good morning.
Dr. David, hello, how are you? So we have the first
Hello,
speaker with
how
us.
are you?
Dr. David, are there other session moderators also with us for this session? Dr. Vishal, are you there?
Yes, yes. Please go ahead.
So we'll like to start this session of ocular oncology, and our first speaker is Dr. David. Dr. David is going to talk about management pearls in small pigment choroidal tumors. Dr. David is a professor of ophthalmology at University of Buenos Aires, where he heads the Department of VR and
Yeah, I'm
Ocular
here, sir.
Oncology. Ocular Oncology, and he's also the coordinator of Laboratory of Ophthalmic Research and Visual Sciences at the Pathology Department at the university. He has multiple publications in dealing with ocular oncology and retina, especially macular edema. and is also the editor-in-chief of Latin America Ophthalmology of Journal of Ophthalmology. Dr. David, kindly begin your talk, please. Thank you so much.
Thank you for the presentation. Please let me know if you can see the slides.
Yes, sir, we can see your slide.
Excellent, excellent. Well, first of all, thank you for the invitation. And in the next few minutes, we're talking about the management with fine needle aspiration biopsy and small pigment choroidal tumors. As you know, the classical clinical presentation of this tumor have different factors of risk, like a grow, orange pigments, subretinal fluid, a grow, a loss of vision, but all of these clinical aspects are prognostic factor, but are not pathognomonic of the small uveal melanomas. And if the tumor have a medium or high size, the ultrasound can confirm the clinical diagnosis. But the problem is when the tumor have a size of less of 3 millimeters grow, as we publish with the American Joint Cancer Commission in the British Journal in 2022. And this year, we can see what is really important regarding the size of the tumors and the prognostics of the patient. As you can see here in this publication of Nature, in the size of the tumors, we have really a time we can make the clinical diagnosis because the tumor is very small, but we start to grow around 1 millimeter, the tumors can to duplicate it. And in general, we treat the tumor with 2 or 3 millimeter. But as you can see here, at the time the tumor is very slow, also is only a precursor lesion, we can the tumor can send cells, to the circulation. And they make especially stop in the liver. And then also when we have success in the treatment of the tumor, we have 10 or 15 years metastatic disease in this patient, because when the tumor is very, very small, between 2 or 3 millimeters, is the time of micrometastasis start to see them. And when we have the treatment of the primary tumor, we already have tumor cells in the liver, and for different circumstances, included the mutation, can start to work, and is really our main problem. So in these small cases, we really don't know if it's a small melanoma or a small pigment lesion. We need to take samples. And of course, the best way is we can make a fine needle aspiration biopsy or directly biopsy by vitrectomy. So in these cases, we use the fine needle aspiration biopsy, as you can see here. The classical technique is with a 25G needle, and the aspiration, different way, depends the location of the tumor, transscleral, clear corneal, for take the sample is a technique with some complication. The more frequent is the hemorrhage, in vitro or subretinal, as you can see here in these cases. It's very infrequent, the retinal detachment, perforation, lesion of the lens, and really we never see local dissemination, but in some papers, KISS report, we can see this complication. So with the 20G needle, it's really, really difficult to know how many of the needle is inside the tumor to take the sample. So we designed with Dr. Sin and published in British Journal more of 10 years ago this cannula. We changed the angle of the needle, is more smaller, less aggressive, and all this point here is 1 millimeter to 1 to 5 millimeters. So we know how many is the area of the needle inside the tumor to take the sample in this tumor less of 3 millimeters. 4 or 5 years ago, we published a second generation of this cannula, and with the transparency of this part, because here is the area where the cells are at the end of the surgery. And the other good thing with this cannula, you can put in the aspiration of the vitrectomy machine, and only with the aspiration you can take the sample. So is very good for tumors in the macular area. Remember, we're talking about tumor of no more of 3 millimeters. The second point is the sample. Formal is not a good idea. The best are these non-hemolytic preservative liquids, because they make an immediately preservation of the cellular morphology and the stabilization of the sample. Also, this sample have second filtration and vortex separation, and use these special glasses. In the circle, you can see here all the cells by electric energy. Put all the cells like is similar to the biopsy. This liquid is used in tumors of the it started with gynecological tumors, and we make the first use in intraocular tumors, published almost 15 years ago in European Journal of Ophthalmology, our FIS series. And as example, we can see these cases. This is a child with 14 years old with a small pigment choroidal tumor in the macular area. Refer this patient because the doctor can see grow with pictures, and also subretinal fluid. You can see here orange pigment and very close to the optic disc, and also with loss of vision. As you can see here, the ultrasound is 2.1, 1.7, 1.9 millimeters, so it's very, very small tumor. So the treatment of these cases, you can see here the subretinal fluid. The treatment of these cases is brachytherapy plaque, but the problem is probably this patient for sure have radiation maculopathy and optic disc radiation. So would be a problem. It's a small child, so we need to know, after spoke with the patient, 100% is a small melanoma. So the decision was make the fine needle aspiration biopsy. You can see here the OCT with the subretinal fluids, the autofluorescence with the fluids and the pigment, and here you can see the surgery. We come in put in the cannula. You can see here the marks, so we know we are less of 2 millimeters inside the tumor. Make aspiration and take the sample. And what happened with this case? As you can see here, the patient unfortunately have a small uveal melanoma, so we can make the treatment with iodine brachytherapy. In this year, we use silicone oil because when one of the important points is we need to have an ocular pathology in the operation room, because we need to know the sample is enough. So in the operation room, we know the patient have a melanoma, and at the end of the surgery, we put silicone oil, because the idea with the silicone oil have less chance of radiation retinopathy, and also make an endolaser, heavy endolaser around the punction. And by the way, we take the sample 3 times, because in the first time is not enough cells to make the diagnosis. So you can see here the 2 months post surgery with the area. You can see here the area with the cannula is inside the tumor here and here too. And also the macula is in good conditions. And we can make the treatment with the confirmation of the diagnosis. In conclusion, in this time of tumors, we have two brands. The observation, so we can make the diagnosis with the tumor is more bigger, with the help of the ultrasound, or we can take a sample to the cytological diagnosis. And what is the difference? The difference is we have the diagnosis with the tumor is very small, or we have the diagnosis with the tumor is too big, and is the time of the tumor make micrometastasis in case the tumor is a melanoma. So we, in general, take the sample and not make the observation, of course, after discuss the different options with the patient. And well, with this new instrumentation, it's more easy to take the sample in a small tumor. And also remember, in the future, it is not only important know if the tumor is an uveal melanoma, also the genetic pattern, especially the gene BIF1, because is the prognosis about the patient have high possibilities to make metastatic disease or not. Thank you for your attention.
Thank you, Dr. David. That was a very interesting talk. So I just have one question to you. Like, where is this needle of yours commercially available?
Well, the Goider Enterprise have the needle, and also now we can make a new model with Arun Singh from Cleveland Clinic. We make together the new design, and you will see in the market at the end of the year, this year or the next one, by a smart technology, is an enterprise in the States.
Yeah, thank you so much. Dr. Vishal, do you have any questions?
Yeah, I think excellent presentation, Dr. Pelis. So about the needle, what you ask, Bikram, I think we have in India a Precon company, and if you can approach them, they can usually make needles with a 1 millimeter calibration from the tip of the needle to your hub. So I think if particularly in Indian context, we don't see this kind of small choroidal melanomas. Unfortunately, we see all medium and large choroidal melanomas. So in our part of the country, so in that context, we usually don't use this kind of needles. But one question what I wanted to ask you, Dr. David, is something related to using 27 gauge cutter or 25 gauge cutter. Do you frequently use only needles, or I think cutter is also there in your armamentarium where you can use to take biopsy, especially for your small choroidal melanomas?
Well, in general, I start from many years ago to use the needle with the mark. So I am very comfortable with the techniques, and I can take samples from very small tumors. But really, I take sample in also medium and high melanoma, but not because I need to know if a melanoma or not, because I need to know the prognostic factor, like the type of cells, lymphocytic infiltration, and more important of all, the genetic pattern. Because depends of the genetic of the tumor, we know if the patient have a metastatic disease or not, so we can make more follow-up of these cases. Because remember, probably when you see, as my second slide, when you see a melanoma with a small, with medium or high size, probably the patient already have in the liver cells of the melanoma. Independence, your treatment is good and very well, and you also make an enucleation. The patient already have these cells in the liver, because these cells, the moment of the tumor is more aggressive, is when the tumor is very small. So the majority of the cases is the time with the cell escape by the blood, by blood.
Thank you.
Can I ask you a question, Dr. Pelais?
Yes.
Very nice presentation. not knowing that you invented the small gauge tip cannulas, the dentists use for local injection very small bore cannulas, and I use them. I used to use them, when in suspicious cases, not even melanomas. About your 14-year-old girl, I understand the urge of the family to make the diagnosis. Definitely, they just want to make sure that this is an odd age for melanoma, so they want a pathology proof for the disease. But on the other hand, if I think loudly about it, wouldn't be a documented growth and enough sign to just put a plaque and get rid of the tumor in those instances? Because you showed that you went 3 times, used silicone oil, you probably did a cataract surgery, and you never know the long-term effects of the hole we created just near the macula. Luckily enough, the plaque will take care of the fibrocyte and the fibrosis that can induce an epiretinal membrane and so forth. Besides the unknown risk of metastasis, also tumor dissemination, we really don't know, how it would happen in 20 years' time or 30 years' time for this young lady. So if I think loudly with you, just if I waited for documented growth and just put a plaque on it with a very isolated eye without going 2 or 3 times or 4 times there, especially that we really don't have a treatment for metastatic disease, even if it's a BRAF positive, even if she will get in 20 years' time metastasis, we actually don't have a prophylactic treatment now. So that the genetics, of course, this is big and this is understandable, but I mean, wouldn't this be another thought for this young lady?
Well, of course, it's two different points. Also, if you want, I also want to put in the discussion other point is you need really very good pathologists in the operation room.
Exactly.
And unless in my country, it's no so easy you have a really good pathology, because it's very difficult to the pathology see only 10 cells and they say, okay, it's a melanoma or it's not. So this is other point of view, But
sometimes they reject the sample. They say we don't have cells in the sample.
Yes,
they reject it. Yeah.
Yes, I am agree with you. Also, probably to make this indication, you need the instrumentation, the pathologists in the operation room, and well, a lot of different points you need to take to consider, because really it's not a treatment of one ophthalmology. It's a multi-team, multitask team you need in these cases. The general oncologist, the ocular pathologist, the genetic. Other point, for example, in these cells, you can mark the BAF1 gene. If the patient have BAF1 gene, the patient have the chance of 75% of has liver metastasis. So you maybe study the liver and the image is okay, but probably this patient have cells with the potential of make metastasis in the next few years. So the follow-up is very strict. And at the moment, the general oncologist sees something, can't start with different treatment, specialists with immunological treatment at this point. But the problem, for example, this tinction is not a stain, it's really monoclonal antibodies. It's not at disposition in Latin America. I only have now the monoclonal antibody. So I think so we can see here one option by selected cases. And of course, if we have all these tools to disposition to make the diagnosis, right? It's more complicated. But I think so. If you see the general ocular oncology, you need to know how tumor you treat. If you have a tumor in the liver, in the heart, in the skin, wherever, the doctor in the first step take a biopsy. In the eye, we don't make this because the complications and also because with the clinical and the ultrasound, we have 97% of the diagnosis, so we don't need to take the biopsy really. But from the point of view of the oncology, it's really something difficult because we treat a tumor as a melanoma, but we don't have the 100% of the security is a melanoma. For example, many years ago, I published in a magazine of Spain archives or something, an uveal melanocytoma. And the uveal melanocytoma, the ultrasound and the clinic is exactly the same of the choroidal melanoma. The choroidal melanocytoma and the choroidal melanoma, you make an ultrasound, you can see the same tumor. You make the clinic, you can see the same tumor. So if you don't take the biopsy, you never made the diagnosis. And I made the diagnosis in these cases because the patient don't want to make the enucleation. So I make a local resection. But I have the idea, I am sure it's a choroidal melanoma. And we can make the local resection. My pathology is not I really don't have idea it's a melanocytoma. So always we have 3%. We are not totally sure it's a melanoma. We have 90% is a melanoma, but always we have this black 3%. And always, well, we know we put in the balance positive, negative, make a biopsy, don't make the biopsy to take the decision. But if it's possible, I always prefer take a sample. In small cases to the diagnosis, in the medium, high cases to the prognosis and to the genetic profile.
Okay. Thank you.
No, can we go to the next talk, please? Thank you, Dr. David.
Okay, thank you. I'm sorry, I have a surgery, so thank you. Very nice the session.
Thank you, sir. Thank you so much.
Good evening, everyone. It's a pleasure to be a part of this forum. Let me introduce Dr. Vishal Rawal. He is a distinguished vitreoretinal surgeon and ocular oncologist from LV Prasad Eye Institute, Hyderabad. He has extensive experience in managing complex retinal disorders and intraocular tumors such as retinoblastoma and choroidal melanoma. And he has published widely in reputed journals. So today he will be sharing his insights on a fascinating topic, optic disc sunburst. Please join me in welcoming Dr. Vishal. Over to you,
Okay.
Dr. Vishal.
Thank you, Abhilasha. Thank you, Weber, for this curated ocular oncology symposium in this Ophthalmologica 2025. And I'll be presenting an interesting case, and I'll be happy to take insights from all the panelists and the moderators. So I have no financial disclosure. So I'll present an interesting case. This is a 171-year-old gentleman who complained of diminution of vision right eye for past 1 month. He had a history of chronic smoker for last 25 years. Other than that, there was no other past ocular history. On examination, right eye basically was completely normal with 20/20 visual acuity, whereas left eye he presented with no perception of light, with RAPD and intraocular pressure of 14 millimeters of mercury. On clinical examination, right eye was absolutely okay, whereas left eye you could see this kind of a large 3 to 4 disc diameter choroidal, or you can say lesion, which was probably arising from the retina. You couldn't make out the margins of the optic disc. The retinal blood vessels look absolutely okay. However, on the surface of the lesion, you could see there was fine vascularity suggesting of intrinsic tumor vascularity. Did a ultrasound based sonography where you could see this lesion again was kind of overhanging the optic, whereas the posterior part of the lesion or did show some kind of small hypoechoic lesion, suggesting of might be there was a intraorbital part also of the lesion, which was involving the optic nerve. The vitreous cavity looks okay with some amount of few membranous and dot echos overlying the lesion, suggestive of highlight attachment. And optical coherence tomography scan passing through the lesion again demonstrated the origin of the tumor. Again, it was kind of from the subretinal space with the presence of subretinal fluid and RPA hyperreflective deposits, suggestive of chronicity. We did an ICG and fluorescein angiography. Again, on ICG, the lesion remained basically kind of more of hypofluorescence, whereas on fluorescein angiography from early to mid to late, you could see the lesion kind of enhanced in terms of its vascularity, which was seen clinically, as well as fluorescein angiography in the late phases, where you could see there was not only the leakage from the surface of the lesion, but also in surrounding the lesion, suggestive of subretinal. On OCT angiography, this was just only done for documentation. Again, you could see in the avascular angioplex slab, where you could see presence of multiple fine vascularity on the surface of the lesion, suggesting of that this might be a highly vascular tumor. An MRI was kind of contemplated again to show on the T1 image, the lesion remained hyperintense, whereas on T2, the lesion remained hypointense with the intraorbital part of the optic nerve looking kind of absolutely normal. So we made provision diagnosis of are we looking at an amelanotic optic disc lesion, whether it was inflammatory, whether it is a vascular, or are we looking at some kind of metastatic lesion primary from some other cancer elsewhere in the body. A whole body PET CT scan was performed, and again on whole body PET CT scan we couldn't find out any kind of primary. So we thought of taking a biopsy from the lesion, and being a vitreoretinal surgeon, I think it is most of us here in the panelists again are all retina specialists. So taking a biopsy from an intraocular lesion remains not that kind of challenging as compared to any other surgeon. So this is a small video again which shows using a 25 gauge cutter where we did a limited core vitrectomy followed by using the cutter, where you can see the cut rate was close to around 5,000 cut rate. And as we kind of tried to take up the biopsy, we could find out the material which was coming from the lesion, which was kind of more of cheesy in nature, which was very soft and came out very easily as compared to the previous biopsies which I have taken for melanoma or even for metastasis. Usually they are kind of very kind of solid and kind of homogeneous. And as expected, there was some amount of bleeding which happened because of the intrinsic vascularity, and which was kind of controlled by increasing the intraocular pressure and doing a fluid exchange. So on cytology, I think this was kind of very helpful for us, particularly in these cases where you could see in the HNE stain, we could see there was a presence of this signet ring cells with acidic and mucic past positive, which kind of thought of a tumor which was more of an adenocarcinoma of origin. Again, on special stains, particularly the PAS stain shows periodic acid stiff positive, whereas on the Elsham blue, again, it shows classical signet ring cells with presence of acidic mucin as well as mucilage. On CK7 cytokeratin, again, this came strongly positive, which showed they are dealing with a tumor was not primarily ocular in origin, but primarily basically from the lung or the aerodigestic tract. The HMB45 stain, what we did to particularly to rule out a melanotic choroidal melanoma, came out to be negative, thereby ruling out melanoma. So on the basis of clinical ancillary imaging and the pathological diagnosis, we confirmed a diagnosis of left ophthalmic metastasis, possibly originating from aerodigestive tract, might be lung or gastric. So we repeated the whole body PET CT scan from some other center, and this time it showed some kind of carinal and a small right side sixth rib lesion. Again, the lesion was very small and it was not able to take any biopsy from that area. So we made a provisional diagnosis of lung or gastric adenocarcinoma. We sent the slides to further assessment to rule out whether it is a lung origin or a gastric origin. And the CK20 and TTF1, which are very specific for lung primaries, both of them came negative, thereby ruling out any primary in the lung. And that's why we made final signet ring gastric adenocarcinoma. The patient was then referred to the medical oncologist to look for further screening if required for any endoscopy, particularly to look for any aerodigestive tract cancer. A lymph node biopsy was also advised. However, the patient deferred for further evaluation because of his poor health status. So in short, I would to summarize that yes, multimodal imaging did help us in kind of knowing that this was a highly vascular tumor, and usually the lesions which kind of originates from the optic disc, very few lesions we come across in the clinic. Usually if they are orangish in color, usually we are dealing with retinal capillary hemangioblastoma. If it is dark brown to black in color, then it is optic nerve melanoma. A lesion originating from the optic disc in the parapapillary area, I think a high index of suspicion should be there for your optic disc metastasis, which constitutes around 5% of your intraocular metastasis. And not but I think as often it is very, very important to take a good history. And in 50% of cases, the patient might present with primary elsewhere in the body, but in few cases, close to 20 to 30% of cases, as an ophthalmologist, we might be the first person to diagnose this as a metastasis. And even though in 90% of cases, you might be able to diagnose the underlying primary, but in few cases, 5 to 10% of cases, despite your imaging or despite your PET CT scan, you might not be able to find the primary. Your role as a ophthalmologist to take the biopsy from the intraocular lesion does helps to cleanse the diagnosis and reduce the mortality and send the patient back to your medical oncologist for further assessment and treatment. Thank you for your patient listening.
Thank you, sir. It was a very interesting case. Any questions from the panelists?
Very interesting case. This is Ihab from Egypt. I would add to the list of differential diagnosis here a retinal associated hamartomas. It can get on the optic nerve. It's difficult to treat, and also sometimes despite the age, I haven't seen and going onto the disc. Maybe.
Yeah, I think a good point. I think retinal astrocytoma does present with this kind of lesion over the optic disc, but then presenting with a no perception of light. And in this age group, I think we usually ruled out any kind of benign lesion. We are basically looking at any kind of malignant lesion, whether it was primarily ocular origin or a metastatic origin. Yes, but I think from the presentation point of view, astrocytoma is one of the differentials.
Okay, thank you.
Dr. Vishal, sorry, can I ask one question?
Yes, Divya.
So yeah, very nice presentation, and indeed proven with biopsy and the histochemical markers. So just the question was in the OCT whether the choroid was also involved, because one of the OCTs which you showed, it looks like it has started from the papillomacular bundle and involved probably the optic nerve sheath also, and that may be the reason why the PL would have got negative, or the vision would have been so significantly decreased.
Yeah, again, the OCT that showed in one of the scans, there was a subtle choroidal involvement, but then again, we don't have the obvious imaging unless until we do a proper enucleation and send the eye for histopathology, where we might show subtle choroidal invasion. But I think no PL, again, as what you correctly pointed out, there's again shows there's the optic nerve involvement, basically not only the intraocular, but might be the intraorbital part of the optic nerve also.
Thank you. Very nice presentation, Dr. Krishna.
So in the interest of time, can we move on to the next presentation? Dr. Aditya, are you there?
Yeah. Yeah, so moving on to the next talk, it's my pleasure to invite Dr. Ihab Saad Othman. He's a professor of ophthalmology at Cairo University and a prolific ocular oncologist and a vitreoretinal surgeon. He did his fellowship in oncology at Wills Eye Hospital, followed by his vitreoretinal fellowship in University of Virginia. And he'll be talking to us about challenges in intraocular tumors and opaque ocular media, challenges in conservative management. Over to you, Dr. Ihab.
Thank you very much, Dr. Aditya. Am I on? Are you guys seeing my presentation?
Yes, we can see your slides. Please, there's this thing. Share your screen on and this thing in the presenters mode. Full screen. We're not able to see the full screen. Yeah, now it's fine. Yeah.
Yeah. Okay. So I think there's some delay from Cairo to everyone else in the world, I guess. So a very nice setup, and thank you guys for the invitation. We meet in our practice every day, very unusual cases like the one we saw, and I'd like to share with you, the how to get to keep thinking about these unusual cases in this very unusual situation. One of those are opaque ocular media that can pose a diagnostic challenge and a dilemma, and we really have to think masquerade and ocular tumors. So this is a 44-year-old male coming with a spontaneous hyphema in the right eye with no light perception vision. There's no bleeding tendency. Basically, he's very healthy, nothing to report. And here the B scan is very important to show on ultrasonography and on MRI the intraocular melanoma. Here it's mushroom shaped and it's really invading everywhere. And the management is clear-cut enucleation, where the histopathology shows the hyphema, the swollen lens inducing secondary glaucoma, and the very much necrotic ghost cells that are unluckily epithelioid in nature, that outgrew the blood supply, and they bled out and ended up by hyphema. Well, not all bleeding are melanoma. This is another gentleman. He's an elderly general in the army, coming with rapid diminution of vision in his left eye over the past 2 weeks, with hand motion, good projection. Well, he has it all. He's diabetic, hypertensive, ischemic, and the ultrasound was besides the vitreous hemorrhage in the eye. The MRI doesn't show much. This is a hyper intense on T1 and hypo or iso intense on T2 weighted image. The lesion is small, not that much of thing. And the guy was really demanding, I want to get my vision back. I want to get my vision back. The decision here was a phaco vitrectomy. We go for the cataract and then just go back for the vitreous hemorrhage, looking up for the mass, the presumed choroidal mass. Here is the bleeding and the apex of the mass. So we decide to just do a cleanup and try to see what's really going on behind. We kind of decapitate the vitreous from surrounding the mass. And we know that this is the tip of the iceberg. Something is going on underneath, and we're trying to resolve the puzzle by doing a vitrectomy. The patient was so ischemic that there is no way to do a general anesthesia on him, and the flirting around the mass and trying to get a grip of what's going on by isolating the mass and trying to see considering the risk of bleeding if this was choroidal mass invading the retina. Here applying active suction, and voila, this is a supraretinal or a pre-retinal hematoma that came from a bleeding macroaneurysm, and we could achieve a rapid recovery of vision, clearing the blood out and clearing the vitreous. And here we go, post-operatively. Well, the clues I haven't mentioned, that the patient was on blood thinners, the blood pressure was really high, he was uncontrolled, and you can really see that this dense hypoechoic line that separates the hemorrhage from the retina. And we really do our ultrasonography in the setup of the oncology center in Egypt, where we can read and look really thoroughly into the mass. This is a pre-retinal hemorrhage and that blood, and we can see the hypoechoic line that separates the supraretinal mass from the retinal mass. This is not a choroidal mass, and this makes the whole difference in the decision making. Well, this is another patient coming from Yemen. His right eye is amblyopic and he has a corneal opacity. Axial length is normal, pseudophakic, and he says that he has an intraocular mass that was sitting there for 10 years. The mass is elevated, it's temporal to the optic nerve in the macular area. It shows a high internal reflectivity and low to high with low to medium echo pattern, and it's quite sizable in this eye that we really cannot see anything about it. So vision was still hand motion, and the patient didn't, he was running away once he heard about enucleation as an option. So here, what we do is we go for a, the patient has been previously operated. We remove the cornea. We remove the fibrosis into the anterior segment. And then we go for a posterior segment using a temporary keratoprothesis for the posterior segment. This is another mass that was very similar to the optic nerve mass in the setup of myelinated nerve fibers. So this is another retinal mass, hopefully not a retinoblastoma. And we try to see what's really going on here. I stained, there was a capsule around the mass, and we kind of flirt around one more time. You see the intrinsic vascularization. Luckily enough, these are not aggressive vessels, and we could really separate the mass from the underlying myelinated nerve fiber and retina. And I was very lucky to see a plane of cleavage that I addressed by kind of shearing the mass off and cutting the rest of the base of the mass from the retina. The retina is still flat. Luckily enough, there is no any injury to the retina, and the mass could be isolated from the retina and the nerve fiber layer. Here's the keratoprothesis. We could just simply get it out by removing one stitch of the keratoprothesis and then placing a graft. This is the post-operative of the patient. Of course, vision didn't improve much, but the lesion showed a hypocellular proliferating astrocytes, plant cells positive on GFAP and S100, and SOX10 was negative in those cases. So this is a reactive retinal astrocytic tumor, what we call a vasoproliferative tumor of the ocular fundus. Usually comes as primary or secondary to a myriad of diseases of the retina. Usually present in the third or fourth decade. Here is on one lesion in here. And I think we should add the myelinated nerve fiber as another reason for reactive hyperplasia, reactive proliferative tumor, vasoproliferative tumor in such instances. Other pathologies that come in the periphery of the retina where we really cannot do a clear fluorescein angiography or clear depiction and presentation of the mass. This gentleman had a complicated cataract surgery, and you can see the aqueous lens falling back. And he showed an intraocular mass 3 months post for 3 years with the recent cataract surgery. On optos, you can see the choroidal mass in the nasal retina. It has a variable internal reflectivity, and this is definitely subretinal. The MRI doesn't add much to your diagnosis. This is typical of any intraocular lesion. Systemic workup was negative. Well, we have a peripheral lesion that can be metastatic, can be hemangioma and hematotic melanoma, other rare entities of the pathology. And we really don't have many choices in those instances, because if we think malignant, the management is different from benign, because brachytherapy can be an option. We do have this in Egypt. But what if the mass would not regress? What if it is benign? And then over 1 year or 2 years' time, we'll be anxious enough to do something about the lesion. What if enucleation? But why? What if the lesion is benign? Surgical excision, yes, why not? It's a nasal mass in the periphery. It's accessible. The patient is young. And then we have to manage the IOL in the same time. And I think the fine needle aspiration here has no role. So we go for a partial lamellar resection. We kind of identify the mass by transillumination. We create our very large flap. And then we go for the deep part of the sclera. the 10% sclera left over. And here is the mass. Actually, it's not a choroidal mass. It's a suprachoroidal mass. And you can see how much difference is. Just we're pushing the choroid away from the lesion, and we're kind of pushing it away. It comes so easily. And we were very lucky that, you know, there is no to minimal bleeding, and the mass can be isolated from the suprachoroidal space. Nice and easy. And totally removed from the eye. Minimal bleeding. We put back the flap, and everything was in order. We explanted the IOL, and we put another IOL in proper position. Well, we're very lucky to have a bland-looking cells. The tumor ended to be very decent vision recovery and unfolding of the mass. This is my final case here. This is an elderly 57-year-old female with 3 months history of diminution of vision in her left eye, and the mass here was intraocular and extraocular. So the fine needle aspiration biopsy revealed a lymphoma. And another case where the fine needle aspiration biopsy showed a plasmacytoma, and we can see the plasma cells. And the difficulty, we're asking the pathologist to bear with us, because this is a very bloody sample for the pathologist to reveal any diagnostic clues. Metastasis is important in the eye, and is important to be considered. It's commonly in the uveal tract. The primary sites are known to be breast, lung, and GIT, and the unknown primary, as was mentioned before, in 20 to 30% of the cases. Now, in very rare cases, we use the fine needle aspiration to confirm uveal metastasis or to resolve uveal melanoma versus metastasis. Here, we use it, frequently for uveal metastasis to confirm other lesions, and we definitely have our limitation, and the prognostication is important. However, in absence of really treatment of metastatic disease, we have to question also the value. In conclusion, obscure intraocular masses in adult pose a diagnostic dilemma. We have our multimodal imaging, we have the PET-CT, different approaches for diagnosis and management, and we have to really have the oncology center that is equipped, and the cooperation between us and the colleagues of different specialties. Thank you very much for the invite, and I hope it's useful.
Thank you, Dr. Ihab, for that excellent set of cases. Before I take some questions, I would like to make a comment and ask your suggestion and experience about peripheral hemorrhagic choroidal retinopathy, like a peripheral PCV lesions also can present with these mimic melanoma-like lesion.
Yes.
They can have hemorrhagic PEDs, which often mimic melanoma on a MRI and ultrasound, and also present with a breakthrough vitreous hemorrhage where we can't directly see them. So do you have any experience with that, and how do you go about that?
Yeah, well, we know the confusion, it comes from that the melanin acts like hemoglobin in different degradation products. So the ultrasound is not helpful. Even the MRI is not helpful, because we can see the pattern, the usual pattern of this being a melanoma. I had a series of patients, but for the time's sake, I haven't put much of those in here. It's always useful to go back to the patient previous investigation, where you can actually see the membrane in an extraocular location years back, and the patient would have remembered to have been injected before for the extramacular hemorrhagic lesions. So this is a very useful trick in those. In extensive hemorrhage surgery, you would know, if you have a clear view, the blocked fluorescence in fluorescein angiography will just tell you immediately that this is not a melanoma. But if you have an extensive blood in the eye and there is no view, you just have to go for vitrectomy, and you can also see the hemorrhage in different grades of degradation, up to fibrosis, up to when you have a like the white fibrosed hemorrhage, where there is no use of doing an extensive extra subretinal surgeries to remove a very fibrotic, difficult to remove kind of amalgam that was set for purposes and to rule out melanomas.
Yeah, thank you. Any questions or comments from other panelists?
Sure. Hi, this is Dr. Divyansh. Very, very nice presentation, Dr. Ahab. So just wanted to add or congratulate you on for your presentation of very kind of presentation of mass lesions, and very aptly showed the ancient schwannoma which you had dissected with a partial uveal sclerouvectomy. Currently, all being VR surgeons, we would want to intervene it from going from inside, but the best way, as you had suggested, is to go from outside rather than going from inside, and it's just stuck on to the choroid and it is not actually invading it, and you were very beautifully dissecting it as what we could see. One more differential of having a presentation like a vitreous hemorrhage or a pigment dispersion is a melanocytoma, a giant melanocytoma in the ciliary body, which can present as pigment dispersion in the vitreous cavity. And we had one of the cases where the pigment dispersion was in the vitreous cavity, no view of fundus, and also was having some kind of a melanocytes which were coming out of the eye. So we were thinking actually it's a melanoma which is causing the extraocular extension, but the biopsy, and once we had sent the vitrectomy sample for the HPE, then we could find out that it was not a melanoma but a melanocytoma. So that is also one of the differentials. But very nice presentation.
I think, yeah, we've met few cases, few unusual cases where the sclera is melting out, and one of them was lymphoma, and it was a pure ocular lymphoma. So what we do is, like as you did, we just chop the head, put a sclera patch at the time, and I think there is room here for anterior tumor for lamellar resection, because once you remove the mass transsclerally with a whole eye technique, between brackets, and then you put a scleral patch, you're very much done with the disease and the sequelae of the disease as well, the vitreous shedding off and the inflammation into the eye, if this eye is judged to be a viable eye that with some preservation of vision as well. So this is a good way. And I think, I've been trained in both oncology and vitreoretinal surgery. So I have both faces, So the transscleral resection is an en-bloc radical excision of the masses, while the endoresection is a debulking technique, and there is no way that you are totally exciting the tumor, So we really have to keep this concept. So these have very specific indications, and transscleral resection has many, many other indications in the setup of melanomas and other tumors as well.
Very true, very true.
In the interest of time, shall we move on to the next talk, please?
Yeah, sure. Good evening, everyone. I have the privilege to introduce Dr. Divyansh Mishra, sir, who is currently working as a consultant, vitreoretina and ocular oncology services at Shankar Eye Hospital, Bangalore, since 2013, and has completed his VR fellowship from Shankar only, Bangalore, mentored by Dr. Mahesh. His topic today is Beyond the Classic, Novel OCT Signatures in Primary Intraocular Lymphomas. Welcome, sir. We shall start now.
Yeah, thank you. So good evening, good morning, or good afternoon to all. And thanks, Dr. Weber, for making me a part of this very interesting webinar of Pan Ophthalmologica on a very auspicious day of World Sight Day. So to continue with my presentation, this is a case which is around 72-year-old male, which had complained with decreased vision in both eyes. He was a diabetic and hypertensive, systemically well controlled. As we can see, the vision in the right eye is 612 and in the left eye is 69, and had cataract also in both eyes. Actually, the patient had presented for us as for a routine cataract evaluation. So when we had seen inside, as we could see, there was some yellowish subretinal lesions. So once we see this kind of lesions, it's like a red flag that there are some lesions which are below the retina, and once it looks yellow, that means obviously your antennas are up. And to understand actually what it is, we continued with further investigation. And the most simplest investigation which we have with us is a OCT, where, as we can see, the usual finding in this case of kind of lesions where you're already suspecting that it may be a lymphoma, older age patient, a yellowish lesion, and that also looks like it to be subretinal. What we are seeing over here is some kind of hyperreflective material which is in the subretinal area, and which is showing like a multiple lumpy, bumpy appearance. And more of the choroid is clear, and the vitreous is showing some kind of a PVD with some dot ecos. And so the next closest investigation what we have is an OCTA. So as we can see, there is a very typical finding in this case, which I was also very intrigued to find, that this patient was showing some kind of an hyperreflectivity, which was not only in their subretinal area, but in the intraretinal area, and was like going into the vitreous cavity. So what was it? So I was thinking whether it is some seismic activity which is going in the subretinal area, and whether it is going to break through into the vitreous cavity and come out. So I was not sure at this point. So I thought whether it is some other lesion, let's try to confirm. So the FFA, as we can see, is showing some kind of a focal leakage at that particular area where we are seeing this hyperreflectivity. Periphery is showing some kind of a fluorescent areas, which can be suggestive of old lymphomatic lesions, and the similar lesion, multiple peripheral lesions are seen in that other eye also. So these are comparative FFA, ICG, early and late photos versus the color photo versus the Octa. What we are seeing over here is actually a sequence or a leakage which is seen from the subretinal space into the retinal space, but I was still not sure what this is. So after discussing with the patient, we thought that, see, right now, considering your age and considering the lesions and considering the very high suspicion that this can be a kind of a lymphomatic lesion, so why not to go for a biopsy? And if not biopsy, what else can be done is probably a therapeutic challenge of a methotrexate. And if patient is still not willing, then we can probably follow up a patient closely and then probably see around 4 to 6 weeks later. And after discussing all this, and suddenly patient started to talk about that he was already a known case of a non-Hodgkin's lymphoma, large B cell in the base of the tongue or tonsil in 2009, which he had already been undergone chemotherapy and radiation, and that was completely under remission. And he went to his oncologist, and it was suggested everything is normal, the PET CT is normal, so this is not the lymphoma, so don't worry, you go ahead with the cataract surgery. And so he didn't come to us because oncologist has told, don't worry, there is nothing at all in the body. So as we can see, once the patient has come 3 months later, there are some new changes. So what we can see is there is increased irregularity in the RP, there is loss of ISOS junction, and there is multiple hyperreflective vertical lines of columns in the retina, what we can see. And yes, the subretinal hyperreflective deposits had increased, or there were multiple other yellowish lesions. So at this point of time, the clear discussion was, no, there is something abnormal going inside the eye. Let's go and do a biopsy. So that's what we have done. So we went ahead and did a vitrectomy where we did a 23 gauge pars plana vitrectomy entering inside after the cataract removal. As what we can see, what we are doing is a biopsy where the cut rate is very low as 200, and then it has to be done with an undiluted sample. So that's why the air was on. And after induction of the PVD and completion of the vitrectomy, the barrage was done around the largest area of the lesion. So I have utilized a cautery to make a small hole, but yes, if we have a 42 gauge or a 38 gauge needle, we can go into the subretinal space and directly suck those lesions. As we can see, using a flute needle, we are able to remove the complete lesion out. There was one more lesion, so I had removed that also, and then given methotrexate. So, and all the aspirate was sent for HPE and flow cytometry, but nothing which came out to be positive as such. But immediate after the injection, as we can see, the PEDs had resolved. So that means the therapeutic challenge has worked, that all those hyperreflective columns which were seen has really resolved. And as we were discussing, those kind of hyperreflective or intraretinal hyperreflectivity or the Octa showing high flow signals have also significantly decreased. Even though the HP was negative, we had got for a second opinion to Dr. KK in Shankar Netralaya and then repeated the PET CT that if there is any intracranial involvement, but nothing came out. So it only suggested that there are some kind of lymphomatous cells, but there was no diagnostic confirmation. So what to do? So patient thought, okay, everything is okay. I've got a good vision. Why to take a treatment? So he again lost for follow-up, and we can see that again those kind of intraretinal vertical columns have again started to recur. So at this point of discussion was that, see, whatever it is, even though we are not able to give you a confirmed clinical diagnosis of lymphoma, let's start treating you as a therapeutic dose of methotrexate, and that's what we continued. So these are all follow-up images of the same patients. As we can see, as and as we were continuing to give the injection, the hyperreflective material, the intraretinal material, everything got near completely resolved. And this is at around 12th week or the 12th injection, which we had seen was there was complete resolution of the irregularity of the RP and a good restoration of ISOS junction. This is a near complete follow-up of simultaneous all the scans of that particular eye, where we were initially seeing those vertical columns had completely resolved, resolution of the subretinal deposit, and whatever the irregularity had come up in the RP or the ISOS junction had also resolved. So what are we looking at? So the question to our panelists or for the discussion is how to confirm a case of diagnosis of an ocular lymphoma in absence of an HPE confirmation. Is presumed ocular lymphoma a separate identity? Because in this case, the patient already had an old history of large B cell lymphoma, but there was no recurrence or relapse as proven by the either PET CT or either the CT scan of the brain. And whether the methotrexate regimen should be continued and how long, because I've already given 12 methotrexate injections and I could see there was already a corneal kind of verticillata which had developed. So is it a toxicity or whether to switch, and how to follow up these cases? And as we were discussing, as these are the novel findings, then I could read up retrospectively in uh, in the literature that these are the newer findings of talking about this vertical columns and the subretinal deposits and loss of ISOS or the RP associations of this lymphoma cell. So yeah, we are open for the discussion or any other comments. Thank you.
Yeah, I think Divyansh, I can take this. As you know, lymphoma is my kind
Sure,
of
Professor.
interest pet topic. So I think the questions what you have asked, I think couple of points related to the biopsy. I think one thing, I understand you took the vitreous biopsy diluted, undiluted, but then when you took the sub RP biopsy with your fluid needle, I think that's where the area of interest, where the highest yield of lymphoma cells is there. So ideally speaking, you should have got the positivity. One thing which I pointed out in your video was that you have used intravitreal triamcinolone to induce PVD. So I would suggest not to use that triamcinolone because steroid itself can cause the lysis of the cells, and that might be detrimental for your biopsy. So next time whenever you're taking the biopsy, don't use any intravitreal triamcinolone or any agent to induce PVD. Usually I don't even induce PVD, or in many of the cases where there's vitritis, there is already PVD is there. So I think that is one pointer which I can see from your video. Second thing is what you told about the vertical kind of things which are going from the sub-RP space into the intraretinal component. So I think this is what is ideally described as intraretinal infiltration, particularly with vitreoretinal lymphomas. And this again has a very good OCT biomarker for your CNS recurrence or CNS relapse or CNS lymphoma happening in near future. So again, in your case, this was a systemic lymphoma. So this was not a primary vitreoretinal lymphoma, but a secondary vitreoretinal lymphoma. So I would not suggest you to go for any MRI brain or CSF tab, but I think whole body PET CT scan, your bone marrow biopsy and serum LDH levels, that should be the way you should be screening these patients, particularly every 6 monthly, to look for any relapse, particularly in the tongue base or anywhere else in the body. Last thing is about the therapeutic trial. Yes, I think as you know, the yield for your biopsy is close to around 60 to 70% only. Despite of all your attempts and everything, if the biopsy comes negative, then you do a therapeutic challenge as you do in your case, and it showed the response. So, but obviously it is not a presume, but I would say confirmed vitreoretinal lymphoma. But your biopsy has come negative. That doesn't make the patient not having lymphoma, and already have a positive history of systemic lymphoma. That again shows that this is a case of vitreoretinal lymphoma, but secondary in origin.
I have a point to add,
Yes, sir.
like you said, IVTH should be avoided. Another thing is the cauterization. Sometimes when you do cautery also, that causes destruction of the lymphoma cells. Number two, when you are suspecting the corneal toxicity due to repeated, ideally the methotrexate injections are 26 in number, considering all the three phases that you do: induction, consolidation, and conservative stages. So when you start having any corneal changes, you start change over to rituximab. I think that takes care of the intravitreal lymphoma. What do you say, Dr. Vishal, about it? Changing to rituximab?
Again, I don't do cautery. I think your soft tip aspiration cannula itself can easily go through in the sub RP space. So I would say avoid doing cautery or anything.
Avoid
Be as
cautery and
minimal
avoid
as possible.
IVTA. That's the major takeaway of biopsy, I think, in these cases.
Yes.
Just wanted to add on to
Rituximab.
switch from. Sorry, sir. Go ahead.
Yeah, go ahead, Divyansh.
So just wanted to add that switch from methotrexate to rituximab, we had one of the cases which had developed idiosyncratic reaction, or means whether it is probably the disease or whether it is due to the injection, we don't know. But the patient had developed kind of a vascular occlusion, like how we see in cases of like IOIs. And then we had to manage it with topical and oral steroids for that particular case. So any experience on that? Some idiosyncratic reactions because of
I have already published a case of occlusive retinal vasculitis as a presenting feature of primary vitreoretinal lymphoma relapse. So that is not yet reported anywhere in the literature, and we could easily see, despite giving what I can vaguely remember, we gave 8 to 12 injections. Then after 2 months, we could see there were new crop of lesions, but we did a fluorescein angiography, and it was a classical occlusive retinal vasculitis. So we had to do pan-retinal photocoagulation along with your intravitreal methotrexate, and that helped the patient to kind of go under remission. So yes, you might get this kind of features.
And rituximab also is known to produce sometimes anti-uveitis and vitritis, which may mimic a lymphoma relapse. So I've had a couple of cases where we were confused. Rituximab were working for 2 injections, and between the second and third injection, patient came with KPs and vitreous haze, but it just resolved completely with a short course of topical steroids. So it can be a feature of rituximab itself, inducing some amount of inflammation. And nowadays, more and more people are moving away from that classic 26 injection in a year pattern, and mostly people are doing 1 injection in every 2 weeks or even once a month injection for 7 to 8 injections, and it is working well. Even I am now switching more to once a month injection in many of the cases, and I don't seem to find any problem so far. The response seems to be okay.
If I may add, Dr. Mishra, you rose a very important question: is the trust between us and the pathologist and the oncologist. We see those masses and we know these are lymphoma, and we can swear to them that these are lymphomas despite the negative pathology, but they don't believe us. And this is a big issue for me, because not all lesions are kind of amenable to pathology diagnosis, and there is the history that backs up the thing. So once you have it's an only eye disease, it's you that you manage. They don't want to know anything about the patient, and it's our duty now to manage. Sometimes we need their help, and they say, no, you're the primary surgeon now to do that as well.
That's right.
Thank you very much for keeping up with the methotrexate, and you have wonderful results on that. The clinical instance of ophthalmology is as good as pathologists. This is what I believe in.
Thank you. Thank you all for the very nice inputs. Thank you.
Thank you, everyone. I think it brings us to the end of the session. Thank you, Divyansh, for the wonderful presentation.
Thank you all, and thank you, Akanksha, for the moderation.
Okay, nice seeing you all. Hope to see you in Egypt.
Yeah, soon.
Thank you.
Bye-bye. Assalam.
Bye. Yeah.
Assalam.